Alright guys, give me like a couple minutes. I'm just gonna go grab my coffee. I'll be right back. Looks like this idiot's back at work again. Oh god. I wonder if he's ever gonna quit. Actually, you know what? This guy's house is now sold. He's finally sold his house, so looking forward to him moving the fuck out of here because I'm tired of his bullshit noises. And like 2 nights ago I fell asleep and the fan that I usually use turned to my face and I woke up super fucking sick. Like my nose is all clogged up. This morning I had mucus everywhere. Like my throat was full, my nose was full, my eyes were full. So I'm just gonna overdose on coffee until I get better. And cough drops. Cough drops are great. We're gonna wait a little bit until more people join real quick. Give them like, it's only been 3 minutes, so we'll give them another 2. I'm also curious to find out what else other people are up to. Like what other things people are doing in preparation of step 1. Because when I was first preparing, I was just all about first aid and UWorld. I never really accessed any other resources in my time. Now there's so much stuff. I love Sketchy, that's about it. Nothing else that I really use. Okay. When we were live yesterday, the second time I got live yesterday, I wasn't able to keep going because of how I'm sick after Eid now. That's a pretty common thing apparently. Like a lot of people, once Ramadan finishes, they get really sick because their body started adjusting to something, but now they're back to eating regularly again. So it's like another readjustment. As for me, I was eating the same all the time, but this fan just had me fucked over. I really hope he's not making too much noise, but he's just as annoying as always. This is where we left off yesterday. We did the Hardy-Weinberg stuff. We talked about this Punnett square. Yeah, everyone is getting a 250 plus, which is really impressive, right? Like you see, I mean, I don't know, we're all taking everything for word, right? So when people say they got a 250 plus, they got a 250 plus, and that's great, good for them. But it feels pretty believable, and I feel like it's because everyone now really understands how to study, right? Because in the beginning, everything was about Kaplan, and other companies weren't really investing into teaching. And now it's become a lot easier to learn everything, which is pretty important because if you didn't learn everything in a very mastered way, then when you become a doctor, you're just going to forget the basics again, and you're not really going to be able to push for certain diagnoses that are very rare. And I think it also came from all these medical TV shows that are out there now. Those medical TV shows have actors that have nothing to do with medicine, but they learn medicine and they talk about it as if they're like, full-fledged doctors. And I feel like those directors and someone else in the staff must have learned how to teach medicine in a very quick and effective way, efficient way. So it came out pretty well. It's something happened. Something definitely happened, and people started learning multiple ways and just started mastering things. So good for them. Good for them. All right, so now we can get started. Hardy-Weinberg populations. We talked about this yesterday. We did this practice question yesterday, right? This was the last thing we did yesterday. We also talked about uniparental disomy and how heterodisomy was not as bad as isodisomy, where you basically just take the whole thing. So if one parent has a disease, you just take the disease, even though the other parent did not have the disease at all. And it's an autosomal recessive disease. So getting an autosomal recessive disease from one parent isn't exactly how that kind of works. So there's that. And then we have now disorders of imprinting, which has a lot to do with uniparental disomy. But before I go into that, I want to look at the rest of these genetics questions I have here, right? Because one of the most important ways to kick ass on step 1 and NBME, or pretty much any test for that matter, is to do practice tests, right? You cannot pass a test if you never actually practiced the test. So let's look at this first question. A healthy 31-year-old woman comes to the office as she and her husband desire a second child. The husband is infertile, and the patient's son, who was conceived via donor insemination, was recently diagnosed with Pompe disease. So if the mother is healthy and perfectly fine, and the son now had Pompe disease because of the donor insemination, then the donor must have been a carrier, right? And in that sense, she must also be a carrier because Pompe is autosomal recessive. This rare autosomal recessive disease is known to affect 1 in 40,000 of the general population. Genetic testing confirms that the patient, which is the mother, is a carrier for the disease. A different sperm donor is selected with no person or family history of Pompe disease, but his own carrier status is unknown. What is the probability of the patient having an affected child with the new sperm donor? Now, when I studied mathematics, right, when you study probability, you learn how to calculate probability, right? And in reality, most people have a pretty nice general understanding of how to calculate probability because we do it all the time, right? Flipping a coin, the chances of landing on tails is 1 out of 2, right? So that probability, that kind of probability calculation is very, very basic, but when more things get added into it, it becomes a little more difficult, right? Like the probability of flipping 2 coins and getting a heads on both of them. So then you have to multiply a half and a half, you would get 1/4 and so on. Here, you have to look at every single thing you're looking at, right? So you have the mother's probability of being a carrier, which is given, and then the new sperm donor's probability of being a carrier, which we don't know, right? So we know the mother's a carrier, we don't know if the dad's a carrier, and then the chances of both of them actually giving that recessive allele to the baby is another thing. That's giving the allele is something that a lot of students tend to forget calculating, right? Like, sure, the mother's a carrier, maybe the dad's a carrier too. Let's assume the dad's a carrier. The chances of them giving that allele also has to be calculated, and that's exactly what a Punnett square does, right? Because you're looking at alleles being given into this child. Each one of these squares is a child, and whether or not they got the allele is what a Punnett square kind of calculates. So if you look at this question, they tell you the mother's a carrier, which gives her a 50% chance of passing the mutant allele, right? She's either going to give the bad allele or a good allele. The donor status is unknown, which means that his risk of being a carrier is pretty much going to be, you're going to have to assume it's the same as the risk of the general population's prevalence, right? So 1 in 40,000. 1 over 40,000 is affected in the general population, so Q squared is 1 over 40,000. That means Q is 1 over 200, right? And then now, once you figure out any one of these things in the equation, P squared, P or Q, you find the rest of them. Right, so if we found everything else, we found Q, we found 2PQ, which is the donor's probability of being a carrier, right? The donor would also have a 50% chance of passing that bad allele, the carrier recessive Pompe disease allele. So the probability of the child being affected is always going to be calculated like this for any question of this type. The probability that the mother gives the recessive allele the probability that the donor is a carrier, which was given from the prevalence of the population, and the probability that the donor also gives the recessive allele. Right? So you have the half times a half. Those two halves right here are pretty much the same as the one that I just mentioned about flipping coins. If you flip two coins at the same time, what are the chances both of them are going to give you a head rather than giving tails? So you do half times half, 1/4 chance that both coins will land on tails. Right, so that's the 1/4, and then the 1/100 for calculating 2pq, and choice C is the answer. Now, with step 1, there's going to be a bunch of other answer choices that will fall into place for considerable mistakes that students will typically make, right? So, for example, a certain student might actually completely forget the half and the half, so 1/100 would be an answer choice. Another student might just do 1/2 and not the other half, so then 1/200 would be an answer choice, and so on and so on. So you got to make sure that you don't really depend on the answer choices when it comes to math. You have to find the answer and just pick it. And finding the correct answer is important, because whatever answer you find doesn't necessarily have to be correct, and your wrong answer that you calculated will also be an answer choice. Now, these next few questions are all different types of questions. These are basically a very simple summary of what kind of genetics questions you can get. Since I'm talking, the cough drop isn't exactly melting. Alright, so a 26-year-old woman comes to the office for follow-up. The patient and her husband want to have a child, and she inquires about the risk of certain genetic conditions, including cystic fibrosis. The patient is from a small city where the carrier for her population is 1/30, and her husband is from another community where the carrier frequency for his population is 1/100. What is the probability that the child will have the disease? It's a very straightforward question, right? The answer is 1/12,000. Very straightforward question. They gave you a lot of information. They didn't try to make it very confusing. And if you're lucky, that's how every question will actually look like to you. Even if they try to make it confusing, it has to look very understandable to you. So since cystic fibrosis is autosomal recessive, you know that there's a 1/4 chance that their child will have it, right? This 1/4 is something you can never forget. We use that same 1/4 over here too, right? A half times a half, because Pompe was also autosomal recessive, and that 1/4 is always coming from the Punnett square, the chance of each parent giving the bad recessive allele. So do not forget that. So we got the 1/4. There's a 1/30 chance that the mother is a carrier, and 1/100 chance that the father is a carrier. So all you really do is multiply all three numbers, and that's it. Just multiply everything across, you get 1/12,000, right? Not always will you be given the 1/30 and the 1/100. Sometimes you have to calculate those guys out by understanding the population information that they might provide to you. But this question was pretty straightforward. And even though it's pretty straightforward, a lot of people, what happens when you get an easy question or a question that looks easy, you end up making it harder for yourself. So, don't do that. A 14-year-old boy experiences severe prolonged bleeding following a tooth extraction. He also has a history of multiple episodes of painful joint swelling following minor trauma. His parents have no bleeding problems. Evaluation shows that the patient has an inherited disorder that one of his parents is a genetic carrier for. His older sister, who does not have this condition, is pregnant. She does not know the sex of her child and asks if her child will be affected. Which of the following is the best estimate that this child will have disease? So, now the only thing that's awkward about this question itself is that this is not how clinic works, right? You can't have the 14-year-old boy presenting and then the older sister who's pregnant is asking you questions now, like who's the patient here? Either way, it's an understandable question. We get what's happening here, right? So the answer is 1/8. Now we got to figure out how do we get there. So first things first, by looking at the symptoms of this guy, right, the 14-year-old boy, you can pretty much figure out he has hemophilia. And whether it's A or B doesn't matter. Both of them are X-linked recessive. It's not going to be hemophilia C because we're just going to assume it's not. One, it's kind of more rare. And two, they didn't give us any information for us to really think it's hemophilia C. Alright, so A or B. So they're both X-linked recessive. So now we have a genetics question on an X-linked recessive disease. Alright, so that already alone freaks out a lot of students because X-linked recessive has a different Hardy-Weinberg mechanism, right? So Hardy-Weinberg, the frequency of an X-linked recessive disease in males is just Q because males only have one X, and in females is Q squared because females have two X's. Right, so that's all it really is. There's nothing to really freak out about. Now, look at the question. The patient is a boy with excessive bleeding and hemarthrosis, suggesting hemophilia A or B. Both diseases are X-linked recessive, coagulation factor deficiencies. The probability that the sister is a carrier is P1, which equals 0.5, because her father does not carry the disease, does not carry the mutation, or he would actually have hemophilia, right? Because there's only one X is all he needs. So her mother carries it and gave one of her two X's to the daughter, right? And that makes complete sense. So that means that the sister has a 50% chance of being a carrier because the mother might have given either the hemophilia X or the normal X to that daughter. And then the probability that the offspring will inherit that X chromosome with the hemophilia gene is also 50%, because now this woman, the daughter who is now a mother and pregnant, can either give the hemophilia X or the normal X to her son, right? And or the daughter. So the probability that the sister will have a boy offspring, right? Because that's the question here now, right? If it's a boy or a girl, right? So the probability that the sister will have a boy offspring is also 50-50, right? Because you're either going to have a boy or a girl. And remember what the question said. The question said, what is the best estimate that the child will have disease? So for the child to have disease, it has to be a boy. Otherwise, the girl will just be a carrier. The daughter will just be a carrier. So that's another 50%. So we got a bunch of 50s. And because the male with one X being mutated X will inherit the disease, right? If the sister has a girl offspring, the girl will only be a carrier and not have the disease. So all this question really ended up being was a half times a half times a half, which is 1/8. That's it. Very straightforward, right? Even though it's an X-linked recessive disease question, and it was getting pretty confusing the way they were terming the question, because it's not a UWorld question. This is like another QBank I had found a long time ago for genetics questions. So, whatever happens, but you just got to think very coherently and logically. Be very, very organized in how you're thinking with genetics questions, and don't skip anything, and don't assume anything either. Like, if you're going to make an assumption, make sure it's a very, very logical assumption. Now, this next one says you are attempting to determine the carrier frequency of disease A, which is autosomal recessive and has an incidence of 0.25% amongst African Americans. Calculate the frequency of carriers in this population. Again, a very straightforward question. They gave you some information, and you can derive a bunch of other information out of it, right? So since they tell you that this disease A is autosomal recessive, don't forget that 1/4 in case you need to use it. And the disease has an incidence of 0.25%. 0.25%, right? So calculate the frequency. So now you know that Q squared, this is Q squared, Q squared must be 1/400. That's what 0.25% is as a fraction, right? It's not 25%. 25% would be 1/4. 0.25% is a very small percentage, and an even smaller format in fractions. So 1/400 is Q squared. That means Q must be 1/20, and then you can calculate P is 19/20 because P plus Q equals 1. So the carrier frequency, right, calculate the frequency of carriers. So every time you read a question, make sure you understand what exactly it is you're looking for. So if you're calculating the frequency of carriers, you know you're looking for 2PQ. So the carrier frequency is 2PQ, which is 1/10. Now, one thing you got to remember, when I presented this question to a student once, and I had answer choices of both 2PQ and PQ, the student was actually a little confused about whether or not they picked the 2PQ value or the PQ value. Carrier frequency is 2PQ, not just PQ. And one of the reasons there's a 2 in front of it is because you can have either PQ or QP, and they both are the same thing. So that's why there's a 2 there. You gotta make sure you calculate both things. So the correct answer is 1/10, which is 2PQ. That's what you were calculating for this question. Now a family presents with 3 children. Their son is affected, but their 2 daughters are not affected. The couple is currently pregnant with their 4th child. Ultrasound indicates it's a male fetus. What is the chance that this child will be affected with disease A, like his brother? All right, so we've already calculated Q squared, PQ, all of that stuff, right? Now they have this family that came, and the question is still related to disease A, and they want to know what is the chance of this 4th child, a son that's about to be born, what are the chances of him having disease? So now we're going to need to just go ahead and use the Punnett square, right? And in an autosomal recessive, when both parents are carriers, the risk to each child is just 1/4. That's all this was. But a lot of students I noticed were actually trying to calculate something other than just looking at a Punnett square and understanding that the chances of anyone in this family getting the disease, being an autosomal recessive disease, is 1/4. That's it, right? It's a very straightforward question. Knowing the basics is going to be the most important part. Without knowing the basics, without having a good grasp of the basics, you're not really going to be able to master this, master questions in genetics very well. So make sure you understand how these things are working. It's really not that complicated. But it takes time. It definitely takes time. Now they say the eldest daughter is 20 years old and is concerned about her risk of having an affected child when she marries a non-related African-American man. What is the risk that she will have an affected child? So for an autosomal recessive disease, 1/4 is affected, 2/4 are carriers, and 1/4 are homozygous normal, right? 1/4 is homozygous normal. In such a pedigree, a normal sibling has a 2/3 risk of being a carrier and 1/3 chance of being homozygous normal. Now this 2/3 and 1/3 was something that a lot of students had a lot of difficulty grasping, but it's actually not brand new information. This is not something I'm introducing. It's actually in the book itself. Right, if you look at right here, see? 2/3 probability of being a carrier. Anytime you talk about an autosomal recessive disease, 2 out of these 3 have the red A, right? 2/3 chance of pretty much being a carrier, right? And this last one here isn't exactly a carrier. This person actually has the disease, but having the disease also qualifies you as a carrier too. You carry the disease. All right, so 2/3 have a carrier. 1/3 have the chance. Where is it now? 1/3 have a chance of being homozygous normal, which is exactly up here. This is the one with no lowercase a at all, right? So don't get confused if you see this 2/3, 1/3. That is a very real thing for autosomal recessive diseases. So because we're trying to figure out, whether or not they're going to have an affected child, you use that 2/3, right? Because 2/3 are going to be carriers, right? 2/3 are going to be carriers. Out of these three, 2 of these are carriers, right? This third one has the disease itself. So that's the 3. The denominator 3 is coming from these 3 guys having a lowercase a, but only 2 of them are unaffected by the disease because they're simply carriers. So an unrelated man has the carrier frequency of the general population. Oh, sorry, I skipped this part. This part over here was basically saying that if she's a carrier, then you use the 2/3, and then 1/2 is the 50% chance of her passing on that allele. So 2/3 times 1/2 gives you 1/3 for her. Right, so there's a 1/3 chance for the eldest daughter, which is the mother of that new family that's coming out. An unrelated man has the carrier frequency of the general population, which is about 1/10. That's what we kind of calculated in the first part of this question. So all you gotta do now is, and then again the 1/2, right? Because 1/10 chance of being a carrier, but multiply by 1/2 because 50% chance of actually passing on that allele. And you get 1/20. So the probability of having an affected child is thus 2/3 times 1/2 and 1/10 times 1/2, which is 1/60. Right? Or the 1/3 times 1/20, which is 1/60. And that's it. Alright, so this question, you got to make sure you remember how to actually get from the beginning to the end. This 3-part question here helps you kind of just organize everything and figure out what you would be doing if your original question had just jumped to this gun. Right, you would get one question, and that last question would just be the only question you would get. So you would have to calculate all of this by yourself, then figure out the autosomal recessive Punnett square is 1/4, right? And then go ahead and solve this. But do not forget the halves, the 50% chance of passing on an allele. So before we move on to modes of inheritance, we have to look at disorders of imprinting. So disorders of imprinting. Imprinting is where one gene copy is silenced by methylation and only the other copy is expressed. So that causes a parent of origin effect, right? It's a parent of origin effect. So let's see what that means. In Prader-Willi syndrome, the maternally derived gene is silenced, right? So the mother's genes got methylated. Disease now occurs when the paternal allele gets deleted or mutated, right? So you lose both genes. Then, and then they also say, although 25% of cases are due to maternal uniparental disomy. And what that means is that the maternal gene got silenced, but uniparental disomy means all you got were genes from your mother. So, boom, you have Prader-Willi syndrome now. Excuse me. you now have Prader-Willi syndrome because you never actually got a gene from the father, right? Results in hyperphagia, obesity, intellectual disability, hypogonadism, and hypotonia. Right, so for this, I made up a thing. I said that imagine a useless dad who just eats, gets fat, is dumb, has no balls, and is weak. Right, not having balls is the Western way of saying like you're not tough at all. Right. Keep in mind that it is the maternal gene which is imprinted, and the father's gene is the one that got deleted. So the dad left the family. That's basically all that's happening here. But maternal gene being imprinted also should remind you that if it's not maternal imprinting that the question is about, then it's about the maternal uniparental disomy. All right, maternal uniparental disomy. That means all you ever got were genes only from mom. And if all you got were genes from mom and that her genes are methylated, then you just got silenced genes to begin with. All right, associated with mutation or deletion of chromosome 15 of paternal origin. All right, remember parent of origin effect. So the effect that they were talking about is when the paternal allele is deleted or mutated. So chromosome 15 of paternal origin is the one that has to get deleted or mutated for disease to start later on. Father Willie and Angel Mom. That's actually pretty good. I haven't heard that before. Father Willie and Angel Mom. Let me see. What does that tell you? Father Willie and Angel Mom. Oh, okay. Alright, that's actually really good. That's Father Willie and Angel Mom. I've never heard that before at all. Let's put this right here. Right, so you can get very weird, confusing questions, right? Where you can get a question straight up asking you what's the parent, which parental origin is the issue for Prader-Willi syndrome. You have to remember that it's a paternal deletion, right? Or you could get the question about which parent's disomy did it occur in this child, so it has to be uniparental disomy from the mother, because the mother's gene is the one that is silenced. All right, so there's a lot of stuff, silly stuff like that you can get dumb questions on, and on top of that, you also have to identify the symptoms when you see it in the child that's going to present for this question, right? So you have to understand that you're going to have a child who just eats a lot, is obese, has intellectual disability, and probably the hypogonadism is going to be given as well. Angelman syndrome is where the paternally derived UBE3A gene is imprinted or silenced. Disease occurs when the maternal allele is deleted or mutated later on. This results in inappropriate laughter, also known as the happy puppy syndrome, seizures, ataxia, and severe intellectual disability. Right, so different symptoms, right? You don't see the same symptoms anymore. So here I wrote that imagine an overworked mom going crazy. It's a pretty common thing in the Desi family. Just laughs, has seizures, can't stand, and is very dumb because she's just so worn out. Keep in mind that this is paternal imprinting, and the mother's gene is deleted because she's extremely tired. All right, associated with mutations or deletions of the UBE3A gene on the maternal copy of chromosome 15, and only 5% of cases are due to paternal uniparental disomy, where all the genes you got were from dad, and dad's genes are imprinted, so they don't work. Alright, so uniparental disomy is the topic before this because there's a lot of uniparental disomy issues here. And with uniparental disomy, just remember, if you see an autosomal recessive disease and neither of the parents actually have the disease, and then the child, if you have an autosomal recessive disease, right, where only one of the parents is a carrier and the other parent isn't even a carrier, and then the baby got the disease, that's a uniparental disomy issue where you probably had isodisomy occur, and the dad basically replicated his own chromosomes and then gave 2 copies of the same recessive gene to one child. That's uniparental isodisomy, and that's what causes autosomal recessive diseases to pop up in the next offspring, even though parents didn't really both pass on a gene at all. Right, so that's the kind of stuff you want to watch out for. Now, this page is nice to study for anyone who has not yet studied genetics, right? By this point, you should be pretty good at, and when I say by this point, I mean like when you're pretty much getting ready to take step 1, you should be very comfortable with looking at these diagrams, right, and figuring out like what kind of mode of inheritance we're looking at. Right, so for autosomal dominant diseases, every generation is going to have the disease. It does not skip anything. Right? If it's an autosomal dominant disease, whether the mother or the father has it, they will pass it on to at least one offspring in the next generation. It's going to happen. Right? Often pleiotropic, which means multiple apparently unrelated effects. That's a very common thing for autosomal dominant diseases. We talked about the laundry list of vocabulary words. Right? Pleiotropy. I told you guys, think of trophic things for food, right? Trophic things are always food. So tropic is also related to that. And I said that it's one person eating all kinds of food. So it's just multiple unrelated effects occurring in the same disease. Those are usually, that's usually the quality an autosomal dominant disease tends to have. Wow, my nose is so clogged up. Why? Why now? Why do I have to get sick after Ramadan? I feel like fucking crying. I don't have a tissue. Often pleiotropic, and then variably expressive. Variable expression, basically, exactly as the terminology sounds, different between different individuals. So different people who have the same disease might not present the same exact symptoms, because that's what autosomal dominant diseases kind of do to you. Family history is crucial to diagnosis, obviously, with almost any of these genetic diseases, really. And with one affected heterozygous parent, on average, half of the children will be affected, and that's exactly what's happening here. Alright, so this parent here, though, only has one dominant allele. You could have two dominant alleles. If one parent has two dominant alleles, every child will have the disease. Right? But if the parent is only carrying one dominant allele and has one recessive allele, then half of the kids will have the disease. Right? At least half the kids, or a lot of the kids. So you can see in this family over here, don't count the outliers, right? Those are people they married. This circle and that square are people that someone married. This first family has 3 kids, and of those 3 kids, 2 of them have disease. So that's 66% of the children that got disease. Right, so that's autosomal dominant. Autosomal recessive is much more commonly tested. Almost all enzyme deficiencies are autosomal recessive. Wow. With 2 carrier parents on average, 1/4 of the children will be affected. And this 1/4 and the 1/2 and all of that, we've been using that a lot in the calculations we're doing. So 1/4 of children will be affected, and what am I saying? On average, 1/4 of children will be affected, which is this red square, right? Because they got both recessive alleles. Half of the children will be carriers, and then 1/4 will be completely normal. No carriers, neither affected. All right. And you can see this is a pretty empty diagram, right? Only one child has it. Neither of the parents had the disease. Anytime you see neither parents have the disease and one child has it, right, you know it's not autosomal dominant. It has to be either autosomal recessive or it has to be some kind of X-linked thing going on. And then whether or not it's mitochondrial really depends on the genders of people, and we'll get there. So usually seen in only one generation, commonly more severe than dominant disorders, patients often present in childhood, especially if it's an enzyme deficiency. Increased risk in consanguineous families, where basically you marry within the family. Right, so that's obviously a no-no. Do not do that. Marrying cousins, marrying anyone else in the family, no matter how distant of a cousin, is very much unrealistic and not recommended. Don't do it. It's just not necessary. There's more than enough people out there. Unaffected individuals with affected sibling has 2/3 probability of being a carrier. Right, and we already talked about that. The 2/3 is these 2 guys who are carriers out of these 3 who are, all having the lowercase a. One person does not have anything. All right. So 2/3 probability of being a carrier. 2 out of 3 probability of being a carrier. X-linked recessive. Sons of heterozygous mothers have a 50% chance of being affected. No male-to-male transmission, skips generations. So this skipping generations thing is something that a lot of people have struggled with. Honestly, really not that important to catch. Don't worry about it too much. All you're really looking at here is that it's X-linked recessive, right? But an X-linked recessive disease is pretty much an X-linked dominant disease when it comes to a male, right? Because you only have one X. So you can see here, these 2 are married. They have 3 kids, and one of the sons got the disease. This son did not get the disease, right? And this daughter did not get the disease. But you know that these 2 are carriers because the question is kind of telling you that. But on top of that, this mother must be a carrier, right? This mother must be a carrier because she gave that carrier allele to this son, right? And this son got the Y from all the sons. Remember, all the sons generally just get a Y from their father, right? You don't get an X chromosome from your father. Your X chromosomes as a son, your X chromosomes come from your mother. So this son got the bad X chromosome from mother. This son got the good X chromosome from mother. This daughter, they're saying, must be a carrier, and that makes sense because this daughter had a son and she gave him the bad X chromosome. Right? So that's how you know both of these women are carriers for this X-linked recessive disease. Right? Sons of heterozygous mothers have a 50% chance of being affected, no male-to-male transmission, and that no male-to-male transmission is very important because if you see a question where you figured out that the mother is not a carrier, then the father should not be giving the disease to any sons at all, but he might give it to daughters. Right? In fact, all daughters will be a carrier if the father has the disease because the father gives his X to all the daughters. Then you have X-linked dominant, right? So X-linked dominant, there aren't that many examples of X-linked dominance. They tell you which ones there are: Fragile X syndrome, Alport syndrome, and hypophosphatemic rickets. So X-linked dominant, basically here in this example, you're seeing that the father is the one that has the disease, and he only has one X chromosome. And he's going to give that X chromosome to all his daughters, right? So you see this daughter got the disease, this daughter got the disease. This son did not get the disease because this son got his X chromosome from his mom. So he not only does he not have the disease, he's not a carrier either, which is why everything's okay in his family. But if you go back to the two daughters that got the disease, right, as a carrier, as a male who has an X-linked dominant disease, you do not want to have any daughters because you're going to give them your X-linked dominant disease, and then they're going to give it to their children. You see, this daughter gave it to her son, this daughter gave it to one of her daughters, and it's just going to forever go on. So as a person who has an X-linked dominant disease, as a male who has an X-linked dominant disease, you really hope that you're not going to have a daughter because if you do, she's guaranteed to get the disease. All right. Mitochondrial inheritance is pretty cool, and Step 1 loves asking you questions on mitochondrial inheritance because sometimes it's hard to catch, and on top of that, a lot of people tend to forget what the mitochondrial inheritance diseases even are. Right? So first things first, mitochondrial inheritance is very different from what we're seeing over here with the X-linked. In mitochondrial inheritance, what you're always looking for is that it's transmitted only through the mother. All the offsprings of the affected female may show signs of disease. Right? Because everyone, all the children that are born in the family, they get their mitochondria from the mother. You don't get any mitochondria from your dad. So you can see here that this mom she has a disease. They had two kids. They both got the disease. This father did not give disease to anyone, but this daughter gave disease to all the kids again. Right? So it's very similar to X-linked dominant male. A mother with a mitochondrial disease does not want to have any daughters at all because any mother that has a mitochondrial disease, a genetic mitochondrial disease, as a mother, if she has a daughter, that daughter will also give disease to all the kids. It's going to be forever happening. Now this woman over here, if she has any kids, they're all going to have the disease and so on and so on. But with the birth of a son, the disease pretty much just dies off because he's not going to give those mitochondria to anyone. Alright, so pretty fucked up shit that happens, but that's just how genetics works, and you gotta watch out for that. And you need to know the mitochondrial myopathies, right? So there's, they're pretty rare, but they come up on the test, and that's all. You know, as long as it shows up on the test, it's not rare anymore. It's gonna show up, right? There's Malus syndrome. Malus stands for myopathy. Sorry, not myopathy. Mitochondrial encephalomyopathy, lactic acidosis, and stroke-like episodes. That's exactly what MELAS stands for. So if you get a patient who's having these symptoms, you want to watch out for that. It's secondary to the failure of oxidative phosphorylation, which is exactly what mitochondria are key for. Muscle biopsy often shows ragged red fibers, which will be described in many different terminologies. They'll rarely ever call it a ragged red fiber. And it's due to the accumulation of diseased mitochondria in the sarcolemma of the muscle fiber. Right? Mitochondria just aren't working well. The other one is Leber hereditary optic neuropathy, where you have cell death in the optic nerve neurons, leading to subacute bilateral vision loss in teens or young adults, 90% being males, and it's usually permanent. All right? The last thing that isn't in the book is MERRF, which is in this question right here. So the question says a 23-year-old man is being evaluated for myoclonic epilepsy of recent onset. So he's a very young guy with recent onset epilepsy. All right. The episodes are short-lived and triggered by startle. Physical examination reveals proximal muscle weakness. Gomori trichrome stain of a muscle biopsy specimen shows muscle fibers with a blotchy red appearance. No family history is available because the patient is adopted. What is the probability that this patient's one offspring will inherit the disease? Now, given a question like this, where it really doesn't have enough information for you to calculate anything, just go ahead and pick 0%, even if you couldn't remember that this might be a mitochondrial disease, right? But it is 0%, and if you look at answer choices and consider where they could be true, then when you look at the 0% answer choice and try to think where could this be the correct answer, well, it would be the correct answer if it's a mitochondrial disease and this man has it, right? Men do not pass on mitochondria to any of their kids. So it fits into the story very well. And this Gomori trichrome thing they're talking about is exactly what I've pictured over here. So this is how it kind of looks like. The mitochondria is really fucked up. Right? Mitochondria under Gomori trichrome stain showing marked mitochondrial proliferation and a red rim. Succinate dehydrogenase staining is the most sensitive for mitochondrial proliferation. Succinate dehydrogenase is because there's a lot of that in the electron transport chain of mitochondria, so you got to watch out for that. Just little information that can pop up on random questions, right? Now, this page, the most important thing is going to be talking about cystic fibrosis, but they do have lists of autosomal dominant diseases and autosomal recessive diseases. Just for those who haven't really studied this yet, you definitely want to know when you hear about a disease, you should know what its inheritance pattern is, because the questions don't necessarily have to tell you, oh, this disease is autosomal recessive or autosomal dominant or X-linked recessive, etc. You do need to know that. That is expected. Now we're looking at cystic fibrosis. So cystic fibrosis is extremely high yield, right? 2019 did a good job putting in these images that UWorld had first introduced, and I had them in my 2018 PDF as well. You do need to know exactly how everything is going in cystic fibrosis. So it's an autosomal recessive disease. It's a defect in the CFTR gene on chromosome 7. 1 second. Okay. It's commonly a deletion of phenylalanine at the 508 position. Most common lethal genetic disease in Caucasian population. So now you look at the pathophysiology. CFTR encodes an ATP-gated chloride channel, right? And this was the answer choice for many questions I've seen with different students, right? What's not working in this patient is what they'll say. They'll describe a cystic fibrosis patient, and then they'll ask you what's not working in them. So some ATP-gated channel is not working. They might not even write down chloride channel. Just an ATP-gated channel is not working. But that's what's not working. It's an ATP-gated chloride channel that is not working. So you're unable to secrete chloride in the lungs and GI tract, and unable to reabsorb chloride in the sweat glands. And this first sentence pretty much tells you the entire pathophysiology. All right. Without this channel, you are unable to secrete chloride in the lungs and GI tract, and unable to reabsorb chloride in the sweat gland. So with the most common mutation, what happens is you have a misfolded protein, and that protein gets retained in the RER and not transported to the cell membrane. So now you don't do all of this work. So you have low chloride secretion in the lungs and GI tract, right? And because of that, you're going to have increased intracellular chloride and increased compensatory sodium reabsorption via epithelial sodium channels, leading to more water reabsorption. I'm like really getting more sick as I'm talking apparently, or I just feel this way. I'm not sure. It's hard to breathe from my mouth while I'm talking. I didn't think it was going to be this bad. Anyway, so basically NaCl is what's happening here, right? And that's a salt, so water follows salt, so you're just going to have a lot of that. All of this being stuck inside in your lungs and GI tracts causes abnormally thick mucus secreted into the lungs and GI tract, right? And that's not good, because if you have really thick mucus, you're going to be unable to carry out the general function of these organs. There's also an increased sodium reabsorption, which we already talked about, but what it does is that the increased sodium reabsorption causes a more negative transepithelial potential difference. A lot of students don't really know what that means, right? What is a more negative transepithelial potential difference, and how does that have anything to do with sodium reabsorption? So basically what's happening is that sodium being reabsorbed and everything coming back at the same time. Let's look at the airway, right? Because that's what we're talking about right now. When this entire pathophysiology section over here is generally talking about the lungs and GI tract, not the sweat stuff. The sweat stuff isn't what's causing the biggest issue in cystic fibrosis patients. The bigger issue in cystic fibrosis patients is this part right here, which causes all this dehydrated mucus. Right? And where is this more negative transepithelial potential difference coming from? Well, basically, this was the normal mucus, right? So you had chloride outside and sodium being pulled inside, so everything's kind of balanced out. Now, not only is the chloride stuck inside, but you pulled in all this sodium, right? So if it all connects in here the charge should be pretty much 0. Outside, it's more negative. So outside the charge might be like -10. Whereas in the normal case scenario, because of this balance of chloride going outside, sodium coming inside, and of course other things are sending sodium back out and bringing chloride back in, the charges are pretty much balanced everywhere. So we can assume it's sort of like 0 everywhere, just for argument's sake and for example. But over here, because everything is being retained inside or intracellularly and nothing is outside, you have a more negative transepithelial potential difference. The inside is pretty much neutral, outside is very negative. And you have negative things happening outside too, because this, and by negative things I mean bad things, because you have this dehydrated mucus that just gets stuck everywhere, right? And you can't breathe correctly, your ducts are not going to work correctly, your pancreas is not going to work correctly, your lungs are not going to work correctly, and these patients often tend to just die if they're not treated early enough. Diagnosis is made by using the sweat thing. That's the other one, right? So increased chloride concentration in pilocarpine-induced sweat test is diagnostic. And this wasn't really written there before. So now they let you know that you can use pilocarpine to induce sweating and then check the chloride content. Can present with contraction alkalosis and hypokalemia. The extracellular fluid affects analogous to a patient taking a loop diuretic, right? Very similar to, this is another thing you can get a very stupid question on, right? Like you get a question about a cystic fibrosis patient, they talk about all the cystic fibrosis symptoms, and then in the bottom, at the very end, they'll ask you, the symptoms this patient is presenting with will be very similar to someone else who's taking what else, right? Or not the symptoms that the patient is presenting with, but the lab results he's presenting with, for example. Right, so you have to think of loop diuretics. With loop diuretics, loops lose calcium, but loops also lose a lot of other things and reabsorb different things. And that is going to make it very similar with the contraction alkalosis and hypokalemia. All right, and that's because of the extracellular fluid, water, and sodium losses via sweating and concomitant renal, potassium, and H+ wasting. Right, very important, before you even get to renal, very important to know how all these channels work and what they do in the kidney. And then for the newborn screening, just remember immunoreactive trypsinogen. Alright, if you see a question and it straight up just tells you there's high immunoreactive trypsinogen in this child, what must it have? You should know it's cystic fibrosis, and that's it. There's nothing else to talk about there. So again, the bigger pathophysiology issue was everything that's happening in the lungs and GI tract. That's what's going to kill the patient. The diagnostic thing is the increased chloride in the sweat, right? In the sweat, you can tell a different thing is happening, because the channel kind of works the opposite way. In the sweat, the chloride channel brings chloride back in, so you also bring sodium back in. If you can't, then both things get stuck outside, which causes a pretty neutral charge outside, but a more negative transepithelial potential difference on the inner aspect, right? In lungs and GI tract, chloride is supposed to be pulled out into the mucus, right? It's not going to happen. Chloride gets stuck inside, so you pull back sodium and a lot of water. All the water gets pulled back into the cells, so you have dehydrated mucus. So what are the complications that these patients are going to present with? Recurrent pulmonary infections, S. aureus in infancy and Pseudomonas aeruginosa in adults, chronic bronchitis and bronchiectasis, which will present with a reticular nodular pattern on chest x-ray, and you'll see all of that when you get to respiratory. And I already finished respiratory too, so you can see all the x-rays I share in that book on those videos. And then opacification of the sinuses, pancreatic insufficiency, malabsorption with steatorrhea, fat-soluble vitamin A deficiencies, biliary cirrhosis, and liver disease. Right, so it's a very systemic disorder. Everything is getting fucked up. You also note meconium ileus in newborns. Right? Newborns will have a green fecal mass in the distal ileum and dark green emesis. Laparotomy will be needed. Infertility in men. We talked about this when we talked about cardigenic, right? They both have infertility, but in men it's because, in cystic fibrosis is because men are missing the vas deferens, right? But spermatogenesis is not affected, whereas in cardigenic syndrome, spermatogenesis is affected. They're immotile. And subfertility in women because they're going to have thick cervical mucus, whereas in cardigenic syndrome, again, there's no movement of the egg because of lack of actual motility, the ciliary dyskinesia, there's no cilia. You also note nasal polyps and then clubbing of nails, and remember, clubbing of nails is always a sign of hypoxia. So treatment, now they've got some new stuff coming out, right? So treatment, they have chest physiotherapy, albuterol, aerosolized Dornase alpha, DNase, and hypertonic saline facilitate mucus clearance. All of those for mucus clearance. Azithromycin is used as an anti-inflammatory agent, and ibuprofen kind of slows down disease progression. But they have treatment now. In patients with the phenylalanine 508 deletion, a combination of lumacaftor and ivacaftor actually helps. Lumacaftor corrects this misfolded protein and improves their transport to the cell surface. So you're actually going to have a chloride channel now. And ivacaftor opens that chloride channel, improving the chloride transport. Right? All you need is this chloride to be transported correctly, and everything will be much better off. If the chloride cannot be transported, things go astray. So let's look at this question up here. This is a pretty straightforward question up here too. It says a 6-year-old Caucasian boy is brought in for recurrent sinusitis and chronic cough. He has a transepithelial potential difference that is more negative than normal. His nasal mucosa is most likely to demonstrate what physiologic change? And the answer is increased sodium absorption, right? 40% got it right. 38% chose increased chloride secretion, which is exactly what the problem is. They're unable to do chloride secretion. If this patient was able to do chloride secretion, they wouldn't have this disease. Right? The respiratory mucosa image below was given an explanation in intestinal and respiratory epithelia. The cystic fibrosis channel secretes chloride into the lumen and has a tonic inhibitory effect on opening of the epithelium sodium channels, which decreases the sodium reabsorption into the cell. Right? So they basically gave this image, but this is not working. Right? If he had chloride secretion, that would be good, but he doesn't. There's no channel there. So without the channel, chloride is stuck. So sodium and water are reabsorbed more. You get the more negative transepithelial potential difference, and everything just gets fucked up because of the dehydrated mucus. This question down here was just a piss off question where everything is correct. All the answers are correct. It says here, a 4-year-old boy is brought to the office due to a progressively worsening cough for the past 2 days that is productive of yellow sputum. A year ago, he was found to have bilateral lower lobe pulmonary infiltrates on chest x-ray and was diagnosed with pneumonia. The patient has since had 2 additional episodes of pneumonia, each requiring antibiotics for improvement of symptoms. His current chest x-ray again reveals bilateral lower lobe infiltrates, so he has pneumonia again. Further testing shows a high chloride content in his sweat. Which of the following abnormalities is most likely to be seen in this patient? So the most likely was answer choice A, which says abnormal post-translational processing of a transmembrane protein. That is what happens in cystic fibrosis. But I had chosen C, which says defective channel formation by a transmembrane protein. And that also sounds like exactly what happens in cystic fibrosis. And I don't have screenshots of the explanation of this question, and I hope they got rid of the question or changed it by now. But basically, the explanation said C is also possible, but less likely. And it said the same thing for all of these answer choices. So B is also possible, but and then it gave like, oh, there's only a 5% chance that's going to happen, 10% chance that's going to happen, etc., etc. So for B, the decreased transcription of a transmembrane protein is also a possibility for how you can get cystic fibrosis. Presence of a truncated transmembrane protein on the cell surface is another possibility of how you can get cystic fibrosis. And then transmembrane protein with increased regulatory response to cyclic AMP and ATP was also something that was another way to get cystic fibrosis, and it was just really dumb to see that. But it goes to show, when these questions say what is the most likely, you have to pick the better of 2 answer choices, right? And that's often very difficult in multiple choice questions, because you might get yourself down to 2 answer choices, but picking the more correct one can be the challenging part. Also, one thing they kind of removed from here, but was in previous first days, was the mention of N-acetylcysteine. N-acetylcysteine also helps. It can cleave the mucus bonds and mucus glycoproteins to loosen mucus and allow it to be cleared, just like a lot of these other guys that are being used for mucus clearance. And N-acetylcysteine is also the antidote for acetaminophen toxicity and prevents radiocontrast-induced nephropathy. So just extra information there. That's about it for that. Then they list out all the X-linked recessive disorders. Now, X-linked recessive disorders, again, you do need to know how all diseases are inherited. So if they tell you a disease, you don't necessarily have to be told how it's inherited also. You are expected to know it, right? So OTC deficiency, ornithine transcarbamylase deficiency, X-linked recessive. Fabry and Wiskott-Aldrich, ocular albinism, G6PD deficiency is X-linked recessive. Hunter is X-linked recessive. We're going to see this one in immunology, Britain's agammaglobulinemia, hemophilia A and B, Lish-Nehan syndrome, which we already saw yesterday, and Duchenne and Becker, which are coming up next, are all X-linked recessive, right? So X-linked recessive pretty much acts like an X-linked dominant disease when it comes to a male, because males only get one X chromosome. But for women, they'll need two X chromosomes, one from the father and one from the mother, both having the disease to actually get the disease of an X-linked recessive. So X-linked recessive diseases are therefore very, very rare in women. All right. There's also this concept of X inactivation, also known as Lyonization. So basically, this is regarding bar bodies, right? One copy of a female X chromosome forms a transcriptionally inactive bar body. Female carriers variably affected depending on the pattern of inactivation of the X chromosome carrying the mutant versus the normal gene. So what they're saying here is even though women are supposed to get two X chromosomes, which is why they're not really going to get the X-linked recessive disease unless both parents give an X-linked recessive disease, they can still get the disease if they take the normal X and make it a bar body, right? Because it's very random. There's no actual mechanism of choosing which X chromosome becomes a bar body, because the body assumes they're both pretty much very similar and there's no real issue to picking. So if a woman takes all of her good X chromosomes and just makes them all into bar bodies and only the bad X chromosomes are expressed, then a woman can end up getting an X-linked recessive disease simply from one parent being a carrier. And the other case scenario where that can happen is Turner syndrome, where this is a woman with just one X chromosome, right? Females with Turner syndrome, the only reason a patient with Turner syndrome is referred to as a female is because they don't have a Y chromosome. Right? So females with Turner syndrome are more likely to have an X-linked recessive disorder because all they need is for one parent to give that X-linked recessive gene, and that's it. All right. This next page, the rest of this page talks about Duchenne, Becker, and myotonic type 1 muscular dystrophies. Duchenne is an X-linked recessive disorder that typically is due to a frame shift deletion or nonsense mutation. The truncated or absent dystrophin protein will then cause myofiber damage, and dystrophin is the largest protein-coding human gene. So by being the largest protein-coding human gene, there's a very high chance of spontaneous mutations in that gene. Right? Dystrophin helps anchor the muscle fibers, primarily in the skeletal and cardiac muscle. It connects the intracellular cytoskeleton, or actin, to the transmembrane proteins alpha and beta dystroglycan, which are connected to the extracellular matrix. When you don't have dystrophin, none of these connections can actually happen, so muscle won't work correctly, and you get myonecrosis. There's going to be elevated CK, creatine kinase, and elevated aldolase, and genetic testing confirms the diagnosis. Right? Onset is before 5 years of age, and one thing you definitely want to remember is with Duchenne, dilated cardiomyopathy is a common cause of death. Right? So this is a question that a lot of you can just get. They'll describe a patient who's presenting with the Gowers sign, and they might even give you a biopsy and tell you that the muscle is all not working correctly. There's myonecrosis, where did they talk? Pseudohypertrophy of calf muscles due to fibrofatty replacement of muscle. Right, so if they give you all of that and then they tell you that the child died, what could have been the most likely cause of death? You have to remember dilated cardiomyopathy. So very young kid, right? Very young kid, unable to use their muscles correctly. Calf hypertrophy, pseudohypertrophy. Pseudo because it's mostly just full of fat. It's not actually that the muscle is getting bigger. Gower's sign is what they're showing you over here, right? So you see from the floor to get up, he had to use his hands the whole time, and even after standing up, he has lordosis and thigh atrophy. Right, so it's not standing correctly. He's not going to be able to balance himself very well at all. In Becker is very similar but less bad. X-linked recessive disorder, typically due to non-frameshift deletions in dystrophin gene, partially functional instead of truncated, less severe than Duchenne, onset in adolescence or early adulthood, right? So you don't see the Gower sign necessarily, and if you do see the Gower sign, you'll see it in a later on age, like age 9 or 10. Deletions can cause both Duchenne and Becker muscular dystrophies. 2/3 of cases have large deletions spanning one or more exons. So a non-frameshift mutation is basically a mutation that is in the frameshift, right? So within the frame, that means that a number of nucleotides divisible by 3 are added or deleted from the dystrophin gene, right? Because the definition of a frameshift mutation is when you delete either one or two or add one or two nucleotides, right? Because then you basically shift the entire sentence and all the codons change. All the codons change, which means all the nucleotides, all the protein, all the amino acids change that make the protein, right? So you get a completely different protein that usually might not even function. And shifting the frame can actually take normal codons and then change them into stop codons. So you can actually just stop translation entirely and make smaller proteins that are not what you needed, okay? So non-frameshift versus frameshift mutation. The last thing here is a myotonic type 1. Excuse me. And myotonic type 1 is an autosomal dominant muscular dystrophy, right, where these two are X-linked recessive. Here, this is also not just, not only is it an autosomal dominant muscular dystrophy, it's also one that will show you anticipation, right? You're going to see anticipation because it's a trinucleotide repeat, CTG trinucleotide repeat expansion in the DMPK gene, leading to abnormal expression of myotonin protein kinase, which then also leads to myotonia, so you have difficulty releasing the hand from a handshake, muscle wasting, cataracts, testicular atrophy, frontal balding, and arrhythmia, which will usually be the reason they die, the arrhythmia, right? So CTG, to remember that, you can also use it to remember some of the symptoms, which are cataracts, early balding in men, and gonadal atrophy, right? So cataracts, 2P, and gonadal atrophy. I can't remember if I've ever seen a question on myotonic dystrophy type 1, but what you do need to understand is that if you have C's and G's, and this is a trinucleotide repeat, then that's a lot of C's and G's, right? And C's and G's are going to increase the melting point of the DNA heavily. That's a lot of 3 H-bond connections, and having a lot of C's and G's at the same time is really bad for any DNA. It's not supposed to happen. It's a very, very tight DNA that's not really going to separate very easily. So that's something that I've seen being mentioned many times in various articles I've seen, and you just want to make sure you think of those connections while you see this trinucleotide repeat. Rett syndrome is nice. I've seen a question on that. It really sucks to have it. Sporadic disorders seen almost exclusively in girls because males actually just end up dying in utero if they have Rett syndrome. Most cases are caused by de novo mutation of the MECP2 gene on the X chromosome. Symptoms of Rett syndrome usually appear between ages 1 to 4 and are characterized by regression in motor, verbal, and cognitive abilities, as well as ataxia, seizures, growth failure, and a stereotyped hand wringing, which I actually ended up searching on YouTube. If you look at the hand wringing, it is pretty stereotyped. It's very different. No other disease has that kind of hand wringing. So go ahead and check that out, YouTube Rett syndrome hand wringing, and you'll see what they're talking about here. But in a question, you would most likely be told, that the child had a perfectly fine first year, everything was okay. Maybe even the second year, everything was okay. Milestones are all being met. And then on the third year, at age 3 or approaching age 3, the child might have started regressing and going back to older milestones, not achieving the future milestones that they're supposed to, and that is a sign of Rett syndrome. Also make sure it's a girl. It can't be a guy, because if it was a guy with Rett syndrome, he'd be dead already. Fragile X syndrome is another trinucleotide repeat. This one is X-linked dominant. Fragile X is X-linked dominant, so anyone who has even one X chromosome of Fragile X syndrome, they will have the disease. It's a trinucleotide repeat in the FMR1 gene. The trinucleotide is CGG, which again really sucks, right? That's a lot of tight CGs. That's not good for you at all. Very much just like the CTGs over here. A lot of C's and a lot of G's at the end of the DNA are going to be really bad. So what happens here? You get hypermethylation, which causes decreased expression. Right? Most common cause of the inherited intellectual disability, and second most common cause of genetically associated mental deficiency after Down syndrome. So a lot of students have actually asked me what's the difference between the two things, right? So inherited, because this is the most common cause of inherited intellectual disability, because Down syndrome you don't inherit. You don't inherit Down syndrome from either parents or anything. Down syndrome occurs because of a genetic issue. So Fragile X syndrome is inherited and genetic, whereas Down syndrome is not inherited. It's just the number one cause of genetic mental deficiency, right? But it's not inherited. So if you get a question on what is the number one cause of genetic mental retardation, that is Down syndrome, right? But the number one cause of inherited mental retardation is Fragile X. Okay. Findings are, they're really not going to give you, much for this, but findings are post-pubertal macroorchidism, so really enlarged testes, a long face with a large jaw, large everted ears, autism, and mitral valve prolapse, if they really want to test you on that. Right, so everything's just a little bigger than usual. I haven't ever had trouble thinking of the macroorchidism because I always look at this image right here and just think of these as the testes, and just remember that they're really, really big in Fragile X syndrome. Other than that, there really isn't much else you're going to get questioned on for this disease. But do not forget the trinucleotide repeat itself. In fact, they tell you all the trinucleotide repeats next, and you do need to remember them. Right, so Huntington is hunt with a cage, so CAG, and it also helps you remember caudate, acetylcholine, and GABA, right, where the caudate is not going to be there anymore, so you lose acetylcholine and you lose GABA. Myotonic dystrophy is CTG, which we just talked about, cataracts, 2P, and gonadal atrophy. Fragile X we just talked about as well. CGGs is the chin and giant gonads, right? Chin protruding and giant gonads. And then Friedreich's ataxia, which comes much later on, has an ataxic gait, which is GAA. Right? That one is autosomal recessive. So Friedreich's ataxia would be the one that you would really want to get questions on because autosomal recessive stuff is pretty confusing and it's nice and testable. And you can show that multiple people in the family have it, whereas many other people don't have it. Right, so that's something that you want to definitely see and master when we get to it. But it's not here right now. It's going to show up in a much later chapter. The next page here is going to talk about the autosomal trisomies. So these are images regarding those trisomies from, I think, UWorld. So on the left, you're seeing trisomy 13, right, where you have the cutis aplasia. You have microphthalmia, cleft lip and cleft palate. Right, umbilical hernia or an omphalocele. You're going to see renal defects and cardiac defects and rocker bottom feet. Now, a lot of these things are overlapped over here as well, but not entirely. There's no cutis aplasia in trisomy 18. There's rarely umbilical hernia or an omphalocele in trisomy 18. This polydactyly is also pretty unique to trisomy 13, more than 5 fingers on a hand. Right? Whereas in trisomy 18, you get clenched hands with the overlapping fingers. The fingers are overlapped and clenched. It's a very rare kind of clenching that you don't really see in trisomy 13 either. So a lot of things are very specific as well. Even though there is some overlap, there's a lot of things that are very specific. And infants with trisomy 13 will almost never survive. Actually, forget almost. They'll never survive. A trisomy 13 patient, an infant born with trisomy 13 will not live. And trisomy 18 infants also tend to just die. So those don't work. They're not compatible with life. Trisomy 21 isn't so compatible with life per se, but they do survive. They do grow up. And then their lifespan really depends on how bad the other symptoms they have are. So you see in this question, a newborn is examined immediately after an induced vaginal delivery for fetal growth retardation. On visual inspection, the infant has low set ears, a small mandible, and a prominent occiput. The neonate has a weak cry and increased tone of the extremities, including clenched hands with second and fifth digits on top of the third and fourth. So you see the clenched hands thing, you start thinking trisomy 18. Cardiac auscultation reveals a harsh 4 to 6 holosystolic murmur, heard best at the left sternal border. The infant is transferred to the neonatal ICU for further workup. What is the most likely chromosomal abnormality? Edwards. All right. The next one says a small for gestational age infant is born prematurely to a 38-year-old woman who had inconsistent prenatal care. Physical exam shows a small round punched-out lesion with an overlying thin membrane on the scalp, and that's the cutis aplasia. A small membranous sac with a loop of bowel protrudes from his abdominal midline, and that would be your omphalocele. It's sealed inside, right? It's not gastroschisis. Remember the difference between omphalocele and gastroschisis. And omphalocele is going to be inside the sac, right? He's transferred to the neonatal ICU for workup. What's the most likely responsible for his condition? And that's Patau syndrome, right? Trisomy 13. What's actually responsible for the condition is probably her inconsistent prenatal care. And then the next page actually talks about these guys now, right? So first things first, Down syndrome, right? Trisomy 21. Findings are intellectual disability, a flat facies, prominent epicanthal folds, a single palmar crease, incurved fifth finger, a gap between the first and second toes, duodenal atresia, Hirschsprung disease, congenital heart disease, mostly an AV septal defect. And this is very specific to Down syndrome, an AV septal defect, all right? Not an atrial defect or a ventricular defect, no, an AV septal defect. Brush field spots, which I kind of show over here, but you can see better images on Google. Associated with an early onset Alzheimer's disease because chromosome 21 codes for amyloid precursor protein, right? And when you have 3 of them now, you make more amyloid precursor protein. There's also an increased risk of ALL and AML, which we're going to see in leukemias when we get to hematology and oncology. 95% of cases are due to meiotic non-disjunction, which increases with advanced maternal age, but not so significantly. I mean, I know many people who have had, many women who've had kids after age 40. It's really not that significant, but again, whether you call it a small percentage or not, it's a percentage nonetheless, and it can happen. Right? And the reason it can happen is with increased maternal aging, the meiotic non-disjunction becomes more possible because all the DNA that's in the original eggs that have been sitting in the mother since the day she was born, those eggs start getting methylated and the chromosome becomes more difficult to open up. So you get meiotic non-disjunction, and you end up sending 2 chromosome 21s from the mother, and you get 1 chromosome 21 from the dad, so you get trisomy now. And from 1 out of every 1,500 cases in women under age 20 to 1 out of every 25 cases in women over 45. Right? So the statistics do show what they show. But again, many people argue it. I believe it. There's really no reason to have a child after age 40, unless you just got married at age 40. So then, you make sure you follow all protocols and do your best to make sure you avoid Down syndrome. One very common discussion a lot of people, I've had with many people is if you were to find out that the child you're about to give birth to is going to have Down syndrome, would you still deliver the baby? Or would you abort it? That's a very important question to think of. Because I've seen what it's like to have a son, with Down syndrome. There's a couple of family members in my family who have, they're not exactly my cousins, but they're kind of like my cousins. My cousins that have Down syndrome, and I've seen what their parents go through, and it's really ridiculously difficult, right? Not only is it difficult, it's a life that almost feels not really, worth living. So it's a very difficult conversation to have, but it's a very important conversation to have, that if you do find out that you're about to give birth to a child who is going to have Down syndrome, do you keep the child or do you not keep the child? And that's a very interesting debate I do like having with people all the time. It's pretty fun to hear what people have to say about it. The other 4% so 95 and 4, and then there's 1%. So 4% of cases are due to unbalanced Robertsonian translocations, most typically between the chromosomes 14 and 21, where you do the translocation and then you end up having multiple copies of chromosome 21. So you get a trisomy of 21 from the Robertsonian unbalanced translocation. Only 1% of cases are due to post-fertilization mitotic error. So now they have listed over here the 5 A's of Down syndrome, right? Advanced maternal age, duodenal atresia, atrioventricular septal defect, Alzheimer's disease, and AML, ALL. Alright, so all the things that you can see. Now, markers for Down syndrome are high up, and that's always been perfect from remembering that ACG is high and inhibin is high. Right? Inhibin is something you'll learn about much more when we get to reproductive. I have a little information up here about it, but it's really not much to say right here per se. I wrote here the FSA stimulates the secretion of inhibin from granulosa cells of the ovarian follicles in the ovaries. In turn, inhibin suppresses FSH. That's kind of the reproductive system information there. But the other thing is with these markers, like if you look at this table that they have here now, right, for the first trimester screening, beta HCG is only going to be high in trisomy 21, right? And then in the second trimester screening, only trisomy 21 has things that go up, and that's beta HCG and inhibin A. That's it. Everything else is always going to be very low everywhere. So PAP A, for example, is never elevated. And this is because Papa or Dad will never really be happy to know that, you know, a trisomy child might be born. So that's something you want to make sure you remember, because you might get a question where they have, you know, trisomy and beta HCG, Papa, inhibin A, S-triol, AFP, all listed out, and then up and down arrows, and they tell you information and you figure out that the child is going to be trisomy 21. You want to make sure you don't pick an answer choice where they ever have Papa elevated. Papa is never elevated. Right? Beta HCG is only elevated in trisomy 21, mostly because this child will actually survive and this is a real pregnancy. The others are real pregnancies as well, but they won't survive. And then inhibin A is elevated in trisomy 21 as well, right? And that's it. Never is anything else really elevated. This over here is to show you the nucleotranslucency in a screening test. My sister is doing ultrasound courses right now, and she was one day telling me that she's doing ultrasound courses. She was doing her rotation for gynecological ultrasounds, and I talked to her about this. We were just driving somewhere, and I told her, oh, you know what the nucleotranslucency test is? And she had no idea what that was. So I spoke to her about it. I told her, like, oh, that's one of the things that help you figure out if someone's going to have a trisomy 21 Down syndrome patient, Down syndrome baby. And when she took her test, it was actually on it. So that was really cool to know that. Thank God I mentioned it to her, or she would have really, you know, she had never heard of it. It wasn't in any of the stuff she studied. So increased nucleotranslucency, right, as well as hypoplastic nasal bone. All of that would be a big sign to tell you that the child is probably and most likely a Down syndrome child. But no matter what, that's just a screening test, right? Amboss had a question on this where they, you know, also had nucleotranslucency as an answer choice, but it's just a screening test. It's not what's going to give you the diagnosis. Chorionic villus sampling, or CVS, is the diagnostic test of choice at 10 to 13 weeks gestation to confirm suspected Down syndrome. An extra copy of chromosome 21 in the placental tissue confirms this diagnosis. CVS is invasive, and there is a 3% risk of miscarriage. So there's that. But if it's the test of diagnosis, then on paper, you don't care. You just got to pick that as an answer choice. Okay. So we already talked about Edwards and Patel. We already looked at, you know, what we were talking about. This is the clenching of the fingers and their overlap. So it's a very unique kind of overlap. Doesn't really happen. And then there's no cutis aplasia though in 18, so cutis aplasia is more of a trisomy 13 thing. There's also you see in trisomy 18, you don't really have per se the cleft lip and cleft palate, right? So that's like really, you know, a developmental problem that really takes place in Patel for the most part. This is just a list of genetic disorders by chromosome that I do often revisit. So when I was studying, I would come back to this page pretty often, because if you see any of these diseases, you do need to know what chromosome they are on as well. Not as badly as, there's two things. For every disease, you do need to know for sure how it's inherited. Autosomal recessive, dominant, blah, blah. You need to know that for sure. And then what chromosome it's on, you do need to know as well, but not like 100%. You don't have to know, but it's very likely that you do need to know. And it can pop up, right? They can also just tell you what chromosome certain disease is on, and that should help you figure out what disease they're talking about, but not if you don't remember. Okay. Okay, we talked about the Robertsonian translocation right now when we were looking at Down syndrome, right? We said it's 1421 for Down syndrome. So chromosomal translocation that commonly involves chromosome pairs 13, 14, 15, 21, and 22. One of the most common types of translocation is a Robertsonian translocation. Occurs when the long arms of two acrocentric chromosomes, which are basically chromosomes with their centromeres near the end, as in these images, right? These guys are acrocentric. Their centromere is near the top end of these images, right? Not in the center. So the two acrocentric chromosomes fuse at the centromere, and the two short arms are lost. So you see what happened? The normal thing would be like this. This is reciprocal. Then you have non-reciprocal Robertsonian translocation, where you take the long arm of this yellow guy and the long arm of this blue guy and put them together. And you lose the two short arms. That's bad. Okay? So that's one thing that you need to remember. This is another way that you get Down syndrome. Balanced translocations normally do not cause any abnormal phenotype. Alright, but if you have an unbalanced translocation, that can result in miscarriage, stillbirth, and chromosomal imbalance like Down syndrome. So this reciprocal one, like, that's not exactly okay either. It's not supposed to happen. This is not supposed to happen either. But it's not going to lead to death per se. Now, it could, because a lot of these translocations are exactly what lead to cancers. There's a lot of leukemias that are related to various different kinds of translocations. So when we get there, we'll see. But generally speaking, we're really just trying to figure out what a Robertsonian translocation is. And Robertsonian basically means unbalanced, non-reciprocal. So you have the two long arms together and the two short arms are lost. Alright? Then they talk about these two diseases that I've really never seen a question on. Critter-Scott syndrome and Williams syndrome. I've never seen a question on these guys. Not even on UWorld. Not even on AMBOSS. It just hasn't shown up. So Y chromosome apparently is also acrocentric. Is it? Let me see. I can't even keep my eyes open. Like, I'm not sleepy, but my eyes are burning. Yeah, the Y chromosome is acrocentric as well. The Y chromosome is acrocentric. Okay. So Critter-Scott and Williams syndrome. I don't know what to say about them, but I mean, we could read them. So Critter-Scott is basically chromosome 5, 46XX, XY, or 5 short arm. Findings are going to be microcephaly, moderate to severe intellectual disability, and high-pitched crying or meowing, epicanthal folds, and cardiac abnormalities such as VSD. Critter-Scott is very similar to Down syndrome. There isn't a major difference between the two, except this high-pitched crying thing. So if you get a question where they're really talking about crying like a cat, then it should stick to you Critter-Scott syndrome, and you just pick this. Williams syndrome is a congenital microdeletion of the long arm of chromosome 7, the same chromosome that's also related to many other things, right? We saw up here, chromosome 7, Williams syndrome, cystic fibrosis, there's two more things. Here they actually tell you another thing as well. They tell you that the deleted region includes elastin gene. So then findings are distinctive elfin facies, intellectual disability, hypercalcemia, well-developed verbal skills, extreme friendliness with strangers, and cardiovascular problems, markedly supravalvular aortic stenosis and renal artery stenosis. So if you get a little kid with supravalvular aortic stenosis and renal artery stenosis, you should really think of Williams syndrome. And what should come to you when you think of these arteries being stenosed, you got to remember that the reason they're being stenosed is because they lost their compliance. And if it's not high blood pressure that's causing it, then it must be loss of material such as elastin. Alright? And that's really it for those guys. And then the next portion starts talking about biochemistry, nutrition. I'm going to go wash my face real quick and I'll be right back. On the bright side, at least this guy's taking a little break and not making as much noise right now. All right. Now, vitamins are pretty easy now. I remember in the beginning, I used to, tend to forget when I was first studying for step 1. I would forget specific things related to certain vitamin deficiencies and stuff like that. But it's become pretty secondhand now. It's really not that bad. But one thing you definitely don't want to forget is when you have vitamins that are fat soluble, right? A, D, E, and K. There are many diseases that cause fat loss. You don't absorb fat. So anytime you see that, malabsorption syndromes, you always want to remember that the patient might actually be presenting with certain symptoms that aren't related to the malabsorption syndrome directly, but actually a side effect of losing fat-soluble vitamins, right? And step 1 loves using that, right? So they might give you a question about cystic fibrosis, celiac disease, or any other malabsorption syndrome, and the patient might actually be presenting with maybe anemia, right? But it's not actually anemia due to the malabsorption syndrome. It's probably because, they lost vitamin E, for example, right? Or they might have coagulation issues because they lost vitamin K. They might have some kind of level of blindness or some kind of epithelial issues because of vitamin A, and so on and so on. The most commonly tested are usually A, E, and K, not really D when it comes to vitamins for fat-soluble malabsorption syndromes, but definitely make sure you watch out for that, right? As far as water-soluble vitamins are concerned, these guys can show up in any way, in any question, any form whatsoever, so you do need to know them very well and understand what they're used for. But one thing is for sure, B complex deficiencies often result in dermatitis, glossitis, and diarrhea. So these symptoms are pretty unspecific. They don't really point out to any one of these guys directly. And don't forget that vitamin C is not a fat-soluble vitamin, all right? Only A, D, E, and K, all right? What's vitamin F? I haven't really heard of vitamin F. Oh, vitamin F is fat, okay. I did not know that. Vitamin F. What? What did they say? Vitamin F is used to represent linoleic acid, an essential fatty acid that is rich in omega-6. Fats are also known as lipids, and they're incredibly important when it comes to maintaining a strong, healthy stratum corneum. Okay. Related to vitamin D, huh? Alright, I haven't really seen anything like that before. I've never really heard of a vitamin F as well. That's interesting. I've heard of linoleic acid. That's actually something that's in the book, right? Linoleic acid is in metabolism. It's one of the things that you need for alpha ketoacid dehydrogenase, I think. That entire complex needs linoleic acid. That's vitamin F, right? So right there. Alright, so first thing we're looking at, vitamin A, right? Also called retinol. Very rightly so, because it is related to the eye. It's an antioxidant, constituent of visual pigments, retinol, and essential for normal differentiation of epithelial cells into specialized tissue. Now, this one is the one that people tend to forget, right? This is the one that people tend to forget. Everyone remembers the antioxidant. Everyone remembers that it helps with night vision and whatnot. But people definitely tend to forget that it's essential for normal differentiation of epithelial cells into specialized tissue. And the reason I never forget talking about this is because I did a UWorld question, which is this one right here, that I had no idea what they were talking about, but I did get it right. The pancreas of a 22-year-old Caucasian male with recurrent pulmonary infections and finger clubbing shows extensive exocrine gland atrophy and fibrosis. The pancreatic ducts are lined with squamous epithelium with areas of keratinization. The findings of squamous metaplasia in the pancreatic ducts is most likely related to a deficiency of which vitamin? And all the fat-soluble vitamins and then 2 other vitamins were all there. None of them really made any sense. Even vitamin A didn't really make sense to me there. But I just chose vitamin A because the other ones were the ones that, like, I felt like there must have been something I don't know about vitamin A because I was very confident it wasn't E. I was very confident it wasn't vitamin K. Definitely confident it wasn't vitamin D. There's not too much to know about them. Vitamin A, I felt like I did know everything, but I was like, maybe there's something I don't remember. And that was the answer. The patient has cystic fibrosis, and in the pancreas, severe obstruction leads to loss of fat-soluble vitamins. Avitaminosis A, or loss of vitamin A, may contribute to squamous metaplasia of the epithelial lining of pancreatic exocrine ducts. retinoic acid is required to maintain orderly differentiation of specialized epithelia. That's a very important little fact there that you want to make sure you don't forget. And I feel like this question right here is an excellent question. Very well written, and tests on a bunch of very important things right there. Not sure what that is. Okay. So other than that, you have the fact that it's found in the liver and is found in leafy vegetables. Use oral isotretinoin to treat severe cystic acne. And you can use all trans-retinoic acid to treat cancer. It fixes APL, acute promyelocytic leukemia. So vitamin A for leukemia, right? Very nice to know that. And we're going to see when we get to immunology, no, not immunology, when we get to hematology, why all trans-retinoic acid actually helps with APL. This question was pretty straightforward. It's just a 35-year-old female hospitalized with headaches and vomiting. She has a long history of psychiatric illness and is known to practice eccentric dietary habits. Physical findings include papilledema, dry skin, and hepatosplenomegaly. Head CT scan is ordered immediately but is negative for intracranial mass. Which of the following is a likely cause of this patient's condition? So vitamin A toxicity can be acute, chronic, or teratogenic, as we see right here. Right, acute toxicity, chronic toxicity, or teratogenic. She probably has vitamin A overuse, and that toxicity, being chronic, has led to idiopathic intracranial hypertension. All right, that's what she has. Idiopathic intracranial hypertension. There's other symptoms that you can notice as well. Everything is here for that. The teratogenic effects, they don't really talk about per se. Right? They don't talk about the teratogenic effects entirely. Oh, they do. Cleft palate and cardiac abnormalities. Well, they don't go into much specifics there. But what you have to remember is anytime you're giving someone vitamin A, it's very common for young girls to come in for oral isotretinoin to treat severe cystic acne, right? If a young girl or any girl who is capable of getting pregnant comes in to get oral isotretinoin, you have to make sure they have a negative pregnancy test, and you have to give them 2 forms of contraception. It's required. Otherwise, if she ends up getting pregnant for whatever reason, somehow it just happened, it was very unlikely. It was very unlikely when she first visited the clinic, but then maybe she met a guy, he was perfect, blah, 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 she gets pregnant. That child is going to have a cleft palate and cardiac abnormalities. So you can't let that kind of thing get in the way. Make sure you do the negative pregnancy test and 2 forms of contraception, because not doing that will actually cause a doctor to possibly lose their license, right? So you study all your life to get your license, and then you continue struggling the rest of your life to maintain your license and not lose it. So that's vitamin A. Vitamin B. Oh, what was this question up here? Oh yeah, this is actually a really good question too. So a 44-year-old woman comes to the clinic after several near collisions over the past month while driving at night. She also has generalized pruritus. The patient has not seen a physician for several years and has missed several scheduled appointments and takes no medications. On physical exam, her skin is diffusely coarse and dry. Which of the following processes is most likely responsible for these findings? Prolonged biliary obstruction. That was the answer you had to pick. The patient has symptoms of vitamin A deficiency, and her pruritus is due to the PBC she has, primary biliary cholangitis, an autoimmune destruction of small bile ducts in the liver. Without the bile, she's losing all her fat, so she has fat malabsorption, and fat-soluble vitamins need bile to be absorbed. Okay, so it's a very common thing for people to be tested on with the whole fat solubility stuff. So anytime you get a fat malabsorption syndrome, remember the fat soluble vitamins and the fact that you might not be absorbing them very well. There's also bitot spots, which you can see 2 pictures of right here, and corneal degeneration, immunosuppression. Right? Acute toxicity just has very, very non-specific symptoms, but chronic toxicity has hepatic toxicity, hepatic enlargement, arthralgias, idiopathic intracranial hypertension, and alopecia. Now, vitamin B1. Vitamin B1 is thiamine, and anytime you get a patient who's an alcoholic, you want to think of vitamin B1. Right, in thiamine pyrophosphate, it is a cofactor for several dehydrogenase enzyme reactions. And you should know, we haven't done a metabolism yet, but when you look at these enzymes right here, you should know what they're for. Yeah, I don't know why they use that picture there. I really don't know why they use that picture there. In that picture, because it's not a thing for, it's not really a thing for, yeah, right here. So this isn't my picture. This is actually a picture in first aid itself, and that looks like a BiTOF spot right there. But BiTOF spots are not a thing for osteogenesis imperfecta. This image is more so here just to show you the blue sclerae that this guy has, that ring around his eye right there. Right, but the BiTOF spot that you're seeing right here, which I'm not 100% sure it's a BiTOF spot, but that's exactly what I would call a BiTOF spot. That has nothing to do with the osteogenesis imperfecta itself. Right, but here you're seeing osteogenesis imperfecta, and there's no osteogenesis imperfecta thing. Sorry, you're seeing the BiTOF spot, but this is not related to osteogenesis imperfecta at all. And I checked it yesterday too after seeing that picture because I didn't catch it the first time. But yeah, osteogenesis imperfecta, I haven't found anything that has to do with BiTOF spots for them. But yes, vitamin A for sure. And now with vitamin B1, you should be able to recall where these enzymes are used and what they do and how they're regulated every time you ever see them. That's how you know you're ready for step 1. Right? So vitamin B1 is necessary for all of these guys, right? Branched chain ketoacid dehydrogenase, alpha ketoglutarate dehydrogenase, which is in the TCA cycle, pyruvate dehydrogenase, and transketolase. Right? So what happens when you don't have enough vitamin B1? Well, you're going to have impaired glucose breakdown, as you could tell, right? Because you're going to lose the TCA cycle, you're going to lose pyruvate dehydrogenase. Right? So then that leads to ATP depletion. You're also going to lose transketolase, so the HMP shunt isn't working. Right? ATP depletion all around. And that gets worsened when you actually give them glucose. Highly aerobic tissues like the brain and heart are affected first. And in alcoholic or malnourished patients, you always want to give the vitamin before sugar. Basically, story of life, sugar is not good for you, right? So you're going to give vitamin first, and then you're going to give dextrose. To decrease the risk of precipitating Wernicke encephalopathy, if you give them more glucose that they already can't manage well anyway because none of the enzymes are working, you end up precipitating Wernicke encephalopathy and things just go downhill. Diagnosis is made by increase in RBC transketolase activity after giving vitamin B1 administration. Right? So once you give them vitamin B1, if you see more transketolase activity, you're good to go. That must be a patient who had vitamin B1 deficiency, possibly due to alcoholism. All right. So what is Wernicke-Korsakoff syndrome? It's a Wernicke and then the Korsakoff, two different things. So confusion, ophthalmoplegia, and ataxia, which is the classic triad, plus confabulation, personality changes, and memory loss, which is permanent. Damage to the medial dorsal nucleus of the thalamus and the mammillary bodies. Right, so that's Wernicke-Korsakoff. Wernicke is just these guys. Korsakoff is the memory and confabulation and personality stuff. Don't want that to happen. You definitely don't want that to happen. Alcohol prevents vitamin B1 uptake in the small intestine, which leads to a decrease in ATP and increase in lactic acid. All right, so you get all the lactic acidosis issues as well. Now, there's dry beriberi and wet beriberi. Two different kinds of scenarios. You do need to know them both. Dry beriberi is where you have polyneuropathy, symmetrical muscle wasting. That's really the mainstay of dry beriberi, so like this guy right here. Whereas wet beriberi is one of the things for dilated cardiomyopathy. You're going to have high output cardiac failure and edema. Right? No edema in this guy. Wet beriberi patients experience biventricular heart failure, peripheral vasodilation, and edema. That's very important to remember that. Thiamine administration will lead to formation of more ribose 5-phosphate, G3P, which is glucose 3-phosphate, and fructose 6-phosphate. Alright, so because all these cycles will start working again. And that's kind of how you figure out that this person has B1 deficiency, because when you gave it to them, you started making the substrates you were unable to make before. Vitamin B2, riboflavin, this is actually pretty easy to remember. There isn't too much happening for it. It's a component of the flavins FAD and FMN used as cofactors in redox reactions. The succinate dehydrogenase reactions in the TCA cycle also use it. Right, so there's a lot of FAD and FMN that we're going to see when we get to metabolism. And what they generally provide is actually 2-ATP. So the two C's of B2 are chelosis and corneal vascularization. That's really all. Vitamin B2 deficiency. Remember, when you get a question, you also want to see what symptoms the patient is not presenting with, right? So there's no other presentation for this vitamin B2 deficiency except for the chelosis and corneal vascularization. And of course, they're going to have symptoms of lack of TCA cycle activity. So there can be some overlap between B1 and B2, but B1 has many other symptoms as well. And if none of them are mentioned in the question, then it more likely is probably due to vitamin B2 deficiency for whatever that patient has. Here we see vitamin B3 deficiency. Now, after B1, B3 deficiency is the next high-yield big vitamin deficiency that you can get questions on very easily. Right? So B3 is also called niacin. It's a constituent of NAD. Right? B2 was for FAD. This one is for NAD plus and NADP plus, which are also used in redox reactions. Niacin is derived from tryptophan. Right? So that's why heart nerve disease is a big deal here. Synthesis requires vitamins B2 and B6 as well. So if you have B2 deficiency, you can have B3 deficiency. And same thing if you have pyridoxine deficiency, B6 deficiency, that can also lead to B3 deficiency. Vitamin B3 or niacin, when we get to the cardiovascular pharmacology, you'll see that it also helps with dyslipidemia. It's a treatment for that. It lowers VLDL and raises HDL, which is a great thing for you. Right. Now, what happens when you have vitamin B3 deficiency? So in B3 deficiency, you know glossitis, and severe deficiency leads to pellagra. Pellagra is kind of, this is podagra here. Pellagra is really bad. Symptoms of pellagra are diarrhea, dementia, and dermatitis in the C3-C4 dermatome circumferential, around the neck area like that. Pretty much it's not just dermatitis per se, it's actually photodermatitis, right? But they wanted to keep the whole 3Ds thing going. But it's really photodermatitis. You could see he was wearing something, right? But wherever the sun was hitting him is where he got the majority of that dermatitis happening. Broad collar rash or the Kazel necklace rash. Hyperpigmentation of sun-exposed limbs, right? They tell you that. This image here tells you can see niacin metabolism. Right, tryptophan, niacin, and nicotinamide all give you NAD, nicotinamide adenine dinucleotide, using the kynurenine pathway. Then that goes through redox reactions for ATP synthesis. Right, you have NADH, great. Or NAD plus can also go here and give you NADP plus for reductive biosynthesis. All of these are things you need to be able to do. When you run out of niacin or you run out of tryptophan, you are unable to do it. All right. So, what is heart nerve disease? Now, heart nerve disease is actually a renal issue. It's a deficiency of neutral amino acid transporters in the proximal renal tubular cells and on enterocytes, leading to neutral amino acid urea. You lose neutral amino acids in your urine. So, what's going to be the problem there? Well, tryptophan, right? Tryptophan is actually one of those guys you're going to lose. So, you're going to have low tryptophan for conversion to niacin, and you get a lot of pellagra-like symptoms, simply because you lost tryptophan and now are unable to make B3, therefore unable to make NAD plus and NADP plus. So how do you fix this? Well, you treat it with a high protein diet and you supply the person with niacin. You have to give them niacin because they're unable to make their own. That's generally all there is to that. Deficiency of vitamin B3 leads to pellagra, but excess vitamin B3, right? Excess vitamin B3 leads to podagra. Podagra is basically gout. That's basically all that is, right? Because you get facial flushing, and you get hyperglycemia, and you get hyperuricemia, and that's the gout thing that you're seeing here, right? So one more thing that you can get a question on regarding vitamin B3 is that this facial flushing is actually induced by prostaglandins, not histamine, right? So you could avoid this by taking aspirin with the niacin. That's it, all right? But you shouldn't be having excess vitamin B3 anyway, so whatever. But if they really feel like asking you a question on this, then they easily can. So make sure you remember that the facial flushing in an excess vitamin B3 is prostaglandin induced, not histamine. B5 and B6 are pretty straightforward, but very confusing questions do pop up. For B5, it's just pantothenic acid, which I remember as pentothenic acid, right? Penta is for 5. So pentothenic acid. Essential component of coenzyme A. So anytime you see something that has a CoA in the end, it needs vitamin B5. That's it, right? And if you have a lack of vitamin B5, you get very Non-specific symptoms of dermatitis, enteritis, alopecia, adrenal insufficiency. So for a question to really help you pick vitamin B5 as an answer choice, they would have to be talking nonstop about some kind of coenzyme A, something that has a coenzyme A to it. I can't recall a question where I picked vitamin B5 as the answer choice, so I'm not really sure where that's going to pop up. But anytime you see a question where you see CoA, then that's vitamin B5. And I'm going to talk about it every time I do an enzyme where there is CoA. Like, look at this next one right here. This one, acetyl-CoA carboxylase and propanyl-CoA carboxylase. Anyone that has carboxylase in it actually needs vitamin B7, but since it also has CoA in these two, acetyl and propanyl-CoA, those guys also need vitamin B5. Alright, but the carboxylase, all three of these, and many other carboxylase enzymes, they all need vitamin B7. We'll get there. B6 is related to so many different things that you can get any kind of question on it, and it's pretty hard to figure out that they're talking about vitamin B6. It's called pyridoxine. It's converted to pyridoxal phosphate, a cofactor used in transamination, so for ALT and AST, liver enzymes. It's also for decarboxylation reactions, glycogen phosphorylase as well, right? And synthesis of cystathionine, heme, niacin, histamine, and neurotransmitters, including serotonin, epinephrine, norepinephrine, dopamine, and GABA. And that's kind of what I'm showing you guys right here. And these two snippets from later on in the book, when we get to amino acid derivatives and when we get to glycogen phosphorylase doing its job, and when we get to cystathionine synthesis, all of those places we're going to see vitamin B6 being required. Right? This is circling this spot right here where you went from dopa to dopamine. That requires vitamin B6. Right? If you never go from dopa to dopamine, you're not going to make the norepinephrine or epinephrine either. So vitamin B6 deficiency can have many presentations. One that you should really watch out for, though, is the cystathionine part. Right? And this is actually this is a question on that. So down here we have a 5-year-old boy with developmental delay is brought to the office due to difficulty seeing the board at school. Examination shows a boy with a tall, thin habitus with elongated limbs and bilateral lens subluxation. So right away you're thinking Marfan's, right? Because lens subluxation, tall, thin, blah, blah, blah. 4 years later, the patient dies suddenly of a massive cerebrovascular accident. Autopsy shows middle cerebral artery thrombosis and old renal infarcts. His parents wish to know if anything could have been done to prevent his death. Which of the following would have been the most appropriate supplementation for this patient? Very scary question to ask, right? Oh, could I have done anything to save my child? Like, how do you answer that question? Like, yeah, man, you could have just given him vitamin B6. He would have been alive. I'm just going to kill you for not having done that earlier. But, the answer here was the child needed vitamin B6, right? And this is not a patient with just Marfan's, because presenting at age 5 with these symptoms and then dying, right? And the way the question is worded and then having answer choices of vitamins, like this could have been a patient with just Marfan's, but then the question wouldn't be about vitamins and the answer choices wouldn't be about vitamins. But here it is. So now you stop thinking of Marfan syndrome, you start thinking of other diseases that have a marfanoid habitus, and that would be homocystinuria, right? So you can see this patient's presentation is most consistent with homocystinuria, the most common inborn error of methionine metabolism. Clinical manifestations include ectopia lentis and marfanoid habitus. Patients are at risk of thromboembolic occlusion of both large and small vessels, and approximately 50% respond to B6 since it's a cofactor of cystathionine beta synthase. Restrict methionine in the diet as well, and we're going to see exactly what to do with homocystinuria patients in the end of metabolism. Right, but again, B6 deficiency is related to so many different things that you can get a question on it in many different hidden ways. Just make sure that you remember it is related to many things. So if you see one of these things and they want to know why it's not working, the answer could very well be vitamin B6. Right, so what does a vitamin B6 deficiency present with? Convulsions, hyperirritability, peripheral neuropathy because you have a deficiency. Oh, and this deficiency, peripheral neuropathy thingy, this deficiency can actually be induced by acid and oral contraceptives. Another thing to just make this a little harder, right? So a patient taking oral contraceptives, there's so many things to watch out for already as it was. Now you also have B6. So if you get a patient on oral contraceptives and now they feel peripheral neuropathy, that is a deficiency induced by the oral contraceptives. I think we've all probably at some point seen questions about isoniazid and B6 deficiency, right? B6 is actually something you need to give with isoniazid anytime you're treating someone. So a woman on oral contraceptives should also be taking vitamin B6. Okay. And sideroblastic anemia, which is due to impaired hemoglobin synthesis and iron excess, right? Because you have heme. Synthesis of heme requires vitamin B6. And it's not really hard to remember that either, because vitamin B6, when we get to heme synthesis later on, we're going to see that again. And it'll come back. Repetition is one of the main key ways of actually making sure something sticks to you. Reading something once isn't really enough to memorize it. B7 is easy, right? So there's 3 enzymes they mentioned here, 3 different processes, but that's how you know that deficiency is going to cause all 3 of these processes to not work well, right? So you have gluconeogenesis that's not going to work, fatty acid synthesis is not going to work, and odd and branched chain fatty acids are not going to be able to work with, right? So you're not going to be able to do any of these 3 guys, and that's problematic. But now, first aid says in thiamine deficiency, RBC transcutaneous activity increases, but in UWorld it mentions that transcutaneous activity decreases in thiamine deficiency. Yeah. So they're both saying the same thing. First aid said that giving thiamine will increase transcutaneous activity. That's what first aid said. And then UWorld told you transcutaneous activity will not work without thiamine. So the same thing. So the way you diagnose it, in a sense, or one of the ways of diagnosing it, is that without the thiamine, transcutaneous activity was low, but when you gave them thiamine, transcutaneous activity increased. That's what first aid was saying also. Right. So right here, first aid was saying diagnosis is made by increase in transcutaneous activity following vitamin B1 administration. All right. Before the vitamin B1, they do have low transcutaneous activity. All right. So what else are you going to see for vitamin B7? So this image here is just pointing out the specific parts. Those 3 green dots are the specific parts that 1, 2, and 3. Those are the 3 parts where it's not working, because these are the circles that they're pointing out. So what does it do? It's required for carboxylation, right? So 3 carbon became 4 carbon, 2 carbon became 3 carbon, and 3 carbon became 4 carbon. Those guys like that. Any carboxylase enzyme needs vitamin B7. So without it, all 3 of these things kind of don't work anymore. So what happens in deficiency? You get dermatitis, enteritis, and alopecia. Again, pretty non-specific stuff, right? Caused also by long-term antibiotic use or excessive ingestion of raw egg whites, which is actually something that a lot of athletes do, right? So avidin in egg whites avidly binds biotin. So you can get a question about a really athletic person that recently just took on a different lifestyle and food lifestyle, and maybe they work out a lot and they drink a bunch of egg whites every morning, right? So now this person all of a sudden shows up and tells you, man, I've been having dermatitis and I'm losing my hair, now I have alopecia, what the hell is happening to me? And it's all because they lost their vitamin B7. And vitamin B7 is very important for hair, skin, and nails, right? Biotin is a vitamin you take for hair, skin, and nails. And if you're not doing it, you should, because it's great for your skin. So remembering these side effects is not that hard, right? Because that's exactly what you actually take biotin for. But remembering these enzymes also isn't hard anymore, because remember, anytime you see carboxylase, that requires vitamin B7. Anytime you see anytime you see coenzyme A, that requires pantothenic acid, B5. Okay. B9. Now B9 and B12 are pretty big, high yield stuff, right? B9 called folate. Very important for every woman that is looking forward to becoming pregnant to start taking folic acid. You need to. It's not an option to not do it, because then you'll have neural tube defects if you don't do it. Okay, so what happens here? Converted to THF, a coenzyme for 1 carbon transfer or methylation reactions, which happens all the time. We've seen THF in so many different things already. We saw THF when we were making thiamine as well, to make DTMP. It is important for the synthesis of nitrogenous bases in DNA and RNA, which is exactly what I was talking about. Earlier in molecular, we saw THF for DNA synthesis. Found in leafy green vegetables and absorbed in the jejunum. Right, you have to remember that. It's absorbed in the jejunum. A small reserve pool stored primarily in the liver, so having vitamin B9 deficiency is pretty common. Macrocytic megaloblastic anemia, hypersegmented polymorphonuclear cells, glossitis, but no neurologic symptoms, which is what you'll actually see in B12 deficiency. You'll see all the same symptoms, but one more thing, which is neurologic deficiency, neurologic symptoms in B12. So when you do the labs for a B9 patient, B9 deficiency patient, you note elevated homocysteine, but normal methylmalonic acid, seen in alcoholism and pregnancy. All right, so both of these guys need to be given vitamin B9. Right, and it's also something that you can see in a patient who just never eats leafy green vegetables, period, ever. So then that's also going to be another patient who can have vitamin B9 deficiency. Deficiency can be caused by several drugs: phenytoin, sulfonamides, methotrexate. All of these are generally drugs that you give folate with. It's a very common thing. Many drugs people are given, they're told, oh, make sure you take this vitamin with it too. And a lot of people tend to not take the vitamin. They're lazy about it, or they don't understand why they have to take the vitamin, so they opt to not take the vitamin, even though the doctor already prescribed it and gave it to them. And then they start showing back to you with fatigue, and they're like, man, ever since I started your medication, I feel really, really fatigued, and I keep getting like tired because they have this anemia. But it's not the medication per se that did it. Like, yeah, it's using up a lot of your folate, but the reason it's happening to you is because you didn't continue taking the folate vitamin I asked you to. All right. So supplemental maternal folic acid at least 1 month prior to conception and during early pregnancy to decrease the risk of neural tube defects. Right. Very important to start taking Very important to start taking folic acid when a mother, has decided she's going to start trying to get pregnant now. Right, because you want to have all that folate available before the pregnancy kicks in, before the fetus is even close to being there. All right. Let's look at these questions now. So yeah, the first one, 15-year-old boy comes to the office for follow-up. Since childhood, he has suffered from recurrent respiratory infections and chronic diarrhea. He has been hospitalized several times for parenteral antibiotic treatment. Current medications include pancreatic enzyme therapy and a number of dietary supplements. Physical exam shows decreased proprioception and hyporeflexia in the lower extremities. Lab findings are suggestive of mild hemolytic anemia. What caused the hemolytic anemia, or what caused all these symptoms? And the answer must be vitamin E deficiency, right? He has chronic diarrhea and recurrent respiratory infections, which is pretty much a giveaway for cystic fibrosis in this young kid. Right, his history gives away cystic fibrosis, which should then make you think of fat malabsorption, so you lose fat-soluble vitamins. And of all the fat-soluble vitamins, only vitamin E could cause the symptoms of decreased proprioception and hyperreflexia. Remember, vitamin E deficiency actually presents very similar to vitamin B12 deficiency. You do have neurologic symptoms in vitamin E deficiency, so very important to get that down correctly. This question, I always remember, vitamin B12 was also one of the answer choices, and a lot of people picked it, right? Because it's pretty much a giveaway. Like, you see physical exam showing decreased proprioception and hyperreflexia, and you forget that vitamin E deficiency also causes that. We're going to see that when we get there. An elderly immigrant from the Middle East presents to your office complaining of numbness and tingling of his hands and feet. He was diagnosed with pulmonary tuberculosis several months ago and is currently receiving isoniazid and rifampin. Neurologic testing demonstrates sensory ataxia and decreased pain sensation in the distal extremities. This patient's condition is most likely caused by what? And it's obviously going to be B6 deficiency. Isoniazid is actually structurally very similar to pyridoxine. So they both compete for the B6 receptor, and pyridoxine often wins. So B6 is unable to do its job, and you end up having defective end products, right? So isoniazid also increases the urinary excretion of B6 because the B6 never attached to the receptor, so you pee it all out. Isoniazid neuropathy leads to peripheral neuropathy, so make sure you supplement isoniazid taking patients with vitamin B6. This here shows you what happens in vitamin B12 deficiency, which is next. So right here, when we did folate deficiency, we said that labs show elevated homocysteine and normal methylmalonic acid, and no neurologic symptoms are going to be seen in these patients. But in B12 deficiency, B12 has something to do with methylmalonic acid. Right? In B12 deficiency, methylmalonic acid becomes methylmalonyl-CoA, but it's unable to continue becoming succinyl-CoA. Right? So you have a buildup of methylmalonic acid, which then leads to impaired myelin synthesis. So that's how you get the peripheral neuropathy in vitamin B12 deficiency. And you also have the homocysteine thing. So homocysteine will not become methionine, right? So you have all this methyl tetrahydrofolate not becoming THF, and that leads to impaired DNA synthesis, right? That's the anemia part. So what are the enzymes that are not working? Was methylmalonyl-CoA mutase. Remember CoA, so B5 is also necessary for that guy. And methionine synthase, which actually makes methionine. They're not going to be able to. Right, so homocysteine is elevated in both B9 and B12 deficiency. But in B12 deficiency, you also have excess methylmalonic acid. So that leads to impaired myelin synthesis. And we see that here, right? They have their own diagram as well. So you can see B12 being mentioned here, B12 being mentioned here, but there's also mentions of B6, right? Remember we already talked about homocystinuria, where B6 deficiency allows you to not be, well, impairs your ability to make homocysteine into cysteine. B6 deficiency also impairs your ability to take succinyl-CoA and make heme, right? And that's kind of what's happening up here as well, right? Your succinyl-CoA won't become heme. That also causes anemia in these patients. What else is there? So when we look at vitamin B12, B12 is found in animal products. So people who are vegan might not be eating animal products, so they can also become B12 deficient. It's synthesized only by microorganisms, and there's a very large reserve pool stored primarily in the liver. However, it's still very common to have a B12 deficiency. I've had a B12 deficiency at one point as well. Deficiency caused by malabsorption, lack of intrinsic factor, absence of terminal ileum, because B12 is actually absorbed in the ileum, whereas folate was absorbed in the jejunum. Certain drugs like metformin, or insufficient intake because of veganism. So even metformin, which is actually a pretty common medication many diabetics take, can cause B12 deficiency, right? Anti-intrinsic factor antibodies are diagnostic for pernicious anemia. You have antibodies against the intrinsic factor, which actually helps you absorb B12. So what do you note in these patients? You note macrocytic megaloblastic anemia, just like B9 deficiency, hypersegmented PMNs, paresthesias, and subacute combined degeneration. Right, so that's a degeneration of the dorsal columns, your lateral corticospinal tracts, and spinocerebellar tracts. And you need to know what these tracts are capable of, right? You should know exactly what each one of those guys does. You should have that memorized pretty well now. And that's all due to abnormal myelin, as we saw from here, right? Because of methylmalonic acid buildup. Associated with increased serum homocysteine and methylmalonic acid levels, along with secondary folate deficiency. Prolonged deficiency can lead to irreversible nerve damage, so you don't want to get to that point. If your doctor tells you to take your B12 pills, you fucking take them. Some people need to get B12 injections, so you go do that, right? Intramuscular B12 injections are also a great way to get the medication. So here on the side, I have a bunch of notes from UWorld questions that brought up shit that were related to this, but not exactly in UWorld. And I probably got those questions wrong. So I wrote here on the left side, the enzyme methylmalonyl-CoA mutase converts methylmalonyl-CoA to succinyl-CoA, which is part of the TCA. So we're talking about like right here. Right? Methylmalonyl-CoA mutase takes methylmalonyl-CoA into succinyl-CoA. And succinyl-CoA is part of TCA. A deficiency in this enzyme, the methylmalonyl-CoA mutase, or a deficiency in vitamin B12, which is a cofactor, would lead to the autosomal recessive methylmalonic aciduria, characterized by episodes of vomiting, lethargy, profound ketoacidosis, because they can't do TCA. Right? So now they have ketoacidosis, which is fine. Ketoacidosis here isn't a problem. Ketoacidosis here is basically the solution the body found to not being able to use sugar. Hyperammonemia and pancytopenia in infancy. Those are problems. Hyperammonemia and pancytopenia are huge issues, right? It may lead to death due to complications such as cardiomyopathy and pancreatitis. The substrate, methylmalonyl-CoA, is derived from propionyl-CoA, which is formed from the catabolism and digestion of isoleucine, valine, threonine, methionine, thymine, or any odd-chain fatty acids. The enzyme propionyl-CoA carboxylase is responsible for the conversion of propionyl to methylmalonyl-CoA, and we're going to see a lot more of that under metabolism. A deficiency of propionyl-CoA carboxylase leads to the autosomal recessive propionic aciduria, which also presents in neonates with hyperammonemia, vomiting, hypertonia, and seizures, and possibly death. Alright, so there's a bunch of different little aciduria disorders that you got to be aware of. Just make sure you know what you're thinking of when you see a little infant with a seizure. Alright, and ketoacidosis is not a problem. So the way this sentence is written, profound ketoacidosis, is not that ketoacidosis is a bad thing, it's that everything else is a bad thing, and ketoacidosis is what it's doing to save itself. Okay? So this is a URL question right here. It says a 4-year-old girl is brought to the office for routine newborn visit. She's too sleepy to feed and has been vomiting. She has 3 healthy living siblings, but one brother had died in infancy due to low blood sugar. She is tachypneic and dehydrated, and urine has high methylmalonic acid. What lab findings would you expect? So this is exactly what we just read about, right? You're going to expect high urine propionic acid and low serum glucose, high urine ketones because there's going to be ketoacidosis going on, and high serum ammonia. This patient has methylmalonic aciduria due to methylmalonyl-CoA mutase deficiency. Isoleucine, valine, threonine, methionine, and arginine fatty acids normally form propionyl-CoA, which is converted to methylmalonyl-CoA by a Biotin-dependent carboxylation, vitamin B7. Then a B12-dependent reaction forms succinyl-CoA, which goes into TCA. So this baby was unable to do any of that, and that's why she has low blood sugar. Low blood sugar because you cannot do TCA cycle in this baby. Alright, that was the giveaway for this answer choice. So although it might not make any sense when you first look at it because you don't have that background knowledge, I'm mentioning it here so you can go ahead and start understanding that more and more and have that knowledge, because when you're given certain information you should be able to derive what that's about. Alright, let's see, I think that's it for these guys here. Yeah, alright, so vitamin C. Now vitamin C, I've heard a lot of people apparently think vitamin C is also fat soluble, which was really shocking to me to know that, because everyone knows K, right? K-A-D-E, those are the only ones that are fat soluble vitamins. Yes, C is not a B vitamin, but it's not a fat soluble vitamin either. So vitamin C, ascorbic acid, is an antioxidant. It facilitates iron absorption by reducing ferric iron into the ferrous state, right? Fe2 plus is the ferrous state. Ferric is Fe3 plus. Necessary for hydroxylation of proline and lysine, which we talked about when we did collagen synthesis yesterday, right? Collagen synthesis requires vitamin C. If you don't have the hydroxylation of proline and the hydroxylation of lysine, which were steps that were actually taking place inside the cell itself, then you're going to have a problem. It's also necessary for dopamine beta hydroxylase, which converts dopamine to norepinephrine. So you run out of norepinephrine, and that's not going to be good. Found in fruits and vegetables, and is pronounced absorbic acid, which I don't know why, but okay. Ancillary treatment for methemoglobinemia by reducing the ferric to ferrous. And this is something you'll see later on in heme as well when we get to methemoglobinemia. But basically, you need to give them vitamin B6 so you can reduce the ferric to ferrous, because in methemoglobinemia, you use the ferric state of iron. So that's a problem. Deficiency causes scurvy, right? So you're going to get a patient who comes in with swollen gums, easy bruising, petechiae, hemarthrosis, anemia, poor wound healing, perifollicular and subperiosteal hemorrhages, and corkscrew hairs, right? So that's what they're showing you here. Weakened immune response as well. Vitamin C deficiency causes scurvy due to a collagen synthesis defect. Right? And here they're showing you that the hydroxylation, you need that. That if you don't do that, you're not gonna be happy about it. And then over here as well, right? Dopamine becoming norepinephrine, that requires vitamin C. We're gonna see these things later on. We already saw the collagen thing. We're gonna see the dopamine stuff later on. If you have excess vitamin C, right, then what? Well, if you have excess vitamin C, that causes nausea, vomiting, diarrhea, fatigue, calcium oxalate nephrolithiasis. This is when you get questions on, right? Calcium oxalate nephrolithiasis, and that's actually a common thing with excess vitamin C intake. Can increase iron toxicity in predisposed individuals by increasing dietary iron absorption. So predisposed individuals would be people like who have hemochromatosis, or people who get constant transfusions, maybe because they have sickle cell or something, right? So you don't want those patients to be taking vitamin C for any reason whatsoever, and that's about it for that. Vitamin D is pretty straightforward. D3 is cholecalciferol, and you get that from exposure of skin to the sun, ingestion of fish, milk, and plants, right? D2 is ergocalciferol from ingestion of plants, fungi, and yeast. So you could get silly questions if they want to give you silly questions regarding, which one is which. Ashutosh, you said loss of blood sugar because TCA doesn't work, but how is that possible? No, low blood sugar. There's going to be low blood sugar because, let me see, where was I? Yeah, these guys. Yeah, so if the TCA cycle is not working, right, you already started glycolysis. Glycolysis started before the TCA cycle, remember? So you already took your glucose, you already broke it down to pyruvate, but then the TCA cycle is not working, so all the sugar you broke down won't actually enter TCA cycle, and then you have low blood sugar. That's what's happening there. Okay, so they don't exactly have high glucose either. They already used up their glucose. They broke it down. We're gonna see that when we get to metabolism. Let me just right here. So so we already did this step, right? In those patients, they already took their glucose, broke it down all the way to pyruvate, right? And then that pyruvate is supposed to enter the TCA cycle, but it won't because their succinyl-CoA is not going to be there at all. They won't have any succinyl-CoA. So that's why, because they already broke down all their glucose, they do have low blood sugar, right? The only time you have high blood sugar is when you don't have insulin. So that's different, all right? Okay, so vitamin D, you can be asked which one is which, and then they also tell you both are converted to 25-hydroxy D3, which is the storage form, right, in the liver, and to the active form 125-dihydroxy D3, which is known as calcitriol in the kidney. Right, so you need to know where those things happen, as is shown in this image right here. Right, so 7-dehydrocholesterol becomes D3 or D2 based off of where things are coming from. D3 is the skin one, D2 is from dietary intake. Those guys then in the liver become 25-hydroxyvitamin D and get stored, and that was thanks to 25-hydroxylase. Then when you need it to access it, it goes to the kidney, and in the kidney 1-alpha-hydroxylase makes it into 125-dihydroxyvitamin D. And that is able to go exert its effects in the bone to increase mineralization, in the small intestine to increase calcium and phosphate reabsorption, which is the most important part of vitamin D, in the kidneys to increase calcium and phosphate reabsorption as well, and in the parathyroid glands to decrease PTH secretion. See, PTH upregulates this enzyme, and it's negative feedback on itself. All right. So that's kind of what they're talking about all over here, right? Increase intestinal absorption of calcium and phosphate, more bone mineralization, so you put the calcium back in the bone, and increased bone resorption at higher levels. All right. High PTH, low calcium, low phosphate leads to more vitamin D production, right? When you have low calcium, generally speaking, when you have low calcium, that leads to more vitamin D production. Vitamin D feedback inhibits its own production by feedback inhibiting PTH, which then downregulates its own enzyme, right? Without PTH. And calcium, high calcium also stops it. So high calcium is one of the things that's stopping it. When you have low calcium, it no longer stops it, so you make more vitamin D. Right, so the calcium is the main guy causing more vitamin D usage. High PTH leads to increase in calcium reabsorption and decrease in phosphate reabsorption in the kidney. Right, so PTH and vitamin D kind of work together in a sense, right? Because although PTH is phosphate trashing hormone, phosphate is still something that's pretty important for you. You don't want to just lose all your phosphate. But PTH is focused more about increasing calcium reabsorption. Now, you can't reabsorb both at the same time in your kidneys because then they'll combine and you'll make calcium phosphate stones. So that's not good anyway. So you get rid of the phosphate. But vitamin D is able to reabsorb phosphate in the intestines, increase calcium and phosphate absorption in the small intestine, and that is pretty clutch right there, right? So that's how you fill all the phosphate you need. Deposit of organic acids in these three enzyme deficiencies inhibits gluconeogenesis. Yeah, I've never heard that either. Organic acids, enzyme deficiency, inhibit gluconeogenesis. I mean, there's most likely more to that than just the organic acids being present, but I'm not too sure about what that is. One little minuscule fact about vitamin D that's pretty important is for breastfed infants. There's no vitamin D in breast milk, so you have to give oral vitamin D to newborn infants as well as breastfed infants. You have to give them oral vitamin D. Deficiency is exacerbated by pigmented skin and premature birth. And it's not just pigmented skin. In fact, Indian people, Pakistani people, Bangladeshi people, the Desi community people are very commonly vitamin D deficient because we don't really tend to go in the sun much, right? So the brown community or Desi people in general, it's not really part of Indian culture to go get like what do you call it? Go tanning, for example, right? It's not really a thing for us. So being in the sun is pretty rare for brown people in Desi culture. So deficiency of vitamin D is actually very common. I'm always vitamin D deficient, so I've got my vitamin D pills. I'm good to go now, but it just keeps happening, right? So my parents are often vitamin D deficient. Many of my relatives are often vitamin D deficient, and when I worked at a Bangladeshi clinic once here in New York, almost all the patients were prescribed vitamin D because they're just chronically vitamin D deficient, right? Fortunately, it's more of an issue for infants than it is for adults, right? Rickets in children is the problem, right? So you get a deformity such as genoverum or bow legs, like this one right here, and you can get osteomalacia in adults, but that's usually more of an issue for women because they can become after menopause, post menopause, osteomalacia can become even more repellent for women, and then you can also get hypocalcemic tetany if you're also losing your calcium. All right, but again, these are just things you have to watch out for in questions. And deficiency of vitamin D can be caused by malabsorption, obviously, because of fat-soluble necessities. Decreased sun exposure, which is what it is for most of the Desi community. A poor diet, also part of most of the Desi community. Chronic kidney disease, right? You got to watch out for that. Chronic kidney disease is a big one for vitamin D because it's actually activated in the kidney. Right, so that's a problem right there. And chronic kidney disease is pretty progressive. It only gets worse. You can't really fix it. And in advanced liver disease, because that's where you store vitamin D, right? 25-hydroxylase stores 25-hydroxyvitamin D in the liver. So all of these are going to be issues where you can actually lose more of your vitamin D. Okay, I see. You mentions this explanation. Buildup of organic acids occurs in methylmalonyl-CoA mutase deficiency, which inhibits gluconeogenesis. Injustification of low sugar glucose in the question you mentioned. Organic acids occur mutase inhibits gluconeogenesis. Yeah, and well, just losing succinyl-CoA was one of the things for the TCA stuff. But I see what you're saying. You also lose gluconeogenesis, so you have low blood sugar. Right, because generally speaking, when someone has low blood sugar, their body should be able to fix that by doing gluconeogenesis or glycogenolysis, right? But none of it works for them. Even doing gluconeogenesis, let's assume they could do gluconeogenesis and make more sugar, they're immediately going to start breaking it down to use it, right? And then the TCA cycle won't really finish, so all the glucose that they're making will be broken down to pyruvate again, and it won't be able to continue. No TCA cycle is present at all because succinyl-CoA isn't there at all. And succinyl-CoA is used for many different things as well. So if they have any succinyl-CoA, it'll get sent to other parts of the body for other stuff like heme synthesis and whatnot. So it's pretty rough. But yes, that's actually more to add to that. So that makes sense. That's good to see. I haven't seen that question before either, so I'm not sure where. I guess that might be a slightly newer thing. That's good to know though. Okay, thank you. Alright, so now after vitamin D, we have, one last thing. people with granulomas, right? Anytime you get a disease that has a granuloma, you would have excess vitamin D in granulomatous diseases because you have increased activation of vitamin D by macrophages, right? And that's what a granuloma generally is. It's macrophages surrounding the infection. So granulomatous diseases have excess vitamin D activation, and that's going to cause hypercalcemia and hypercalciuria, loss of appetite, stupor. You're going to see all of that. And then you're also going to see all the symptoms of hypercalcemia. There's a whole list of symptoms that hypercalcemia can also cause, right? So does hypocalcemia, but yeah, you just make sure you know the connections of those guys. Next up is vitamin E. So vitamin E is pretty big deal as well, because we just saw earlier, right, that see right here they tell you neurologic presentation may appear similar to vitamin B12 deficiency, but there's no anemia, right? Well, there is anemia, but it's not going to be megaloblastic anemia, right? Megaloblastic anemia is not going to be here. You're not going to have the hypersegmented neutrophils, nor are you going to see the differences of methylmalonic acid or even the homocysteine elevations, any of that. So what happens in vitamin E deficiency? Well, vitamin E is an antioxidant. Specifically, it protects red blood cells and membranes from free radical damage. So the anemia you get in vitamin E deficiency is a different type. As hemolytic anemia, you're not able to protect your red blood cells, so they get lysed. They get attacked by radical damage, free radicals, and they get destroyed. You also see acanthocytosis, which is basically the membrane of the red blood cell getting all messed up. Muscle weakness, demyelination of the posterior columns, which then leads to decreased position and vibration senses, and the spinocerebellar tract, which leads to ataxia, right? So you should know what those tracks do anyway. They didn't need to list it out, but you really got to master that. Like if you haven't yet understood what the dorsal columns and spinocerebellar tract and the corticospinal tracts do, then you should be looking at that every day until you have that memorized. And the path they take, where do they decussate and all that stuff. Vitamin E excess can cause enterocolitis in infants. This is something that is a tiny fact, but can easily be tested, right? You can just get a very simple, easy question, and nothing will make sense, and no other answer choice is going to make sense, and it's just going to look weird to you until you remember that excess vitamin E can cause enterocolitis in infants. High dose supplementation may actually alter metabolism of vitamin K, leading to enhanced anticoagulant effects of warfarin. So another little topic that just becomes a question, right? But this is just the physiology of how these vitamins kind of work. So just watch out for that. But good to know, right? Definitely good to remember that the B12 deficiency stuff looks similar without the hypersegmented neutrophils or the megaloblastic anemia and the elevated methylmalonic acid. Those were only things for B12 deficiency. Vitamin K, just like vitamin D, is also something that is not in breast milk, right? So neonates are given vitamin K injection. This one has to be given in intramuscular injection, whereas vitamin D is given orally at birth, all right? Vitamin K is actually activated by epoxide reductase to the reduced form, which is a cofactor for gamma carboxylation of glutamic acid residues on various proteins required for blood clotting. Right, so you can get an answer choice where the answer is supposed to be vitamin K, but instead of that, they'll say, oh, something that does gamma carboxylation of glutamic acid is missing, right? Or something that is a cofactor for gamma carboxylation is missing, or epoxide reductase is missing. Then all these other ways of mentioning vitamin K are pretty important to watch out for. Vitamin K is necessary for the maturation of clotting factors 2, 7, 9, 10, and proteins C and S. Okay. Warfarin inhibits vitamin K dependent synthesis for these factors and proteins. So what happens when you have deficiency of vitamin K? You get neonatal hemorrhage with elevated PT and PTT, but normal bleeding time. Remember, when we do hematology, we'll see. But basically, PT and PTT are for coagulation. Bleeding time is related to platelets, and neonates have sterile intestines and are unable to synthesize vitamin K. So when you don't give them vitamin K, shit just happens, and PT and PTT will be elevated, right? But they have platelets. They have all the platelets they need, so their bleeding time is going to be fine. It's just they don't have any coagulation because 2, 7, 9, 10 and C and S are not working. Can also occur after prolonged use of broad-spectrum antibiotics in adults, right? That's what that last sentence is for adults. Vitamin K deficiency in an adult can occur after using broad-spectrum antibiotics because synthesizing vitamin K, right, giving antibiotics is very similar to just causing your intestines to become sterile, right? You're killing off all these bacteria, and you shouldn't do that. So it's a common thing to get diarrhea after taking broad-spectrum antibiotics for a long time as well. Last thing here is zinc, right? So zinc is actually one of the vitamins I have on my table up here as well, and it's actually a mineral essential for the activity of so many enzymes, right? 100 plus enzymes. There's a list actually online for what enzymes it's necessary for, and it's also important in the formation of zinc fingers, which are transcription factor motifs. So zinc is something that very few people actually run out of because you find it in all kinds of random foods and drinks. But I haven't, I've been having a weird diet, right? I haven't been eating many things, and I definitely don't indulge myself in all kinds of sugary drinks and stuff lately, ever since I did the keto diet and all that stuff. So I've been taking zinc, and it's a very important vitamin to have. If you do have vitamin deficiency of zinc, then you get delayed wound healing, suppressed immunity, male hypogonadism, and decreased adult hair, right? So that's axillary, facial, and pubic hair. That's what they're talking about when they say adult hair. And that's always going to be a problem because that is not alopecia. That's actually a big sign that this person has a zinc deficiency. You want to watch out for that. If you get a question where you're seeing a grown man, like 30, 40-year-old man, and there's no facial hair, there's no axillary hair, there's no pubic hair, they probably have zinc deficiency. There's also dysgeusia and anosmia, which are pretty unique because you don't see them with any of the other guys, right? So dysgeusia is a condition in which a foul, salty, rancid, or metallic taste sensation persists in the mouth. They have this really weird taste in their tongue. And then anosmia is just anosmia. It's a lack of smell. So all of that is pretty unique. You don't really see that with any of these other vitamin deficiencies. It's also associated with acrodermatitis enteropathica, which is what this picture is. Right? A defect in intestinal zinc absorption can lead to this. This person's skin is all messed up. May predispose to alcoholic cirrhosis, and I've seen people talk about this all the time. Like, how does zinc deficiency predispose to alcoholic cirrhosis? Well, you have to remember, zinc is responsible for a bunch of enzymes, right? So enzymes all have to do with your liver. If you're not making most of these enzymes because you have zinc deficiency, and you're drinking alcohol regularly, like an alcoholic person, then you're going to have liver cirrhosis, right? Because those enzymes aren't working to begin with. And that's it for all your vitamins. The last thing they mention here is protein, energy, malnutrition, right? And we've seen, especially if you're in like a third world country or somewhere that has third world country habitats, you've probably seen a child of both of these types in person. I certainly have in India. Right, so kwashiorkor is a protein malnutrition resulting in skin lesions, edema due to low plasma oncotic pressure, and liver malfunction, where you have fatty change due to low apolipoprotein synthesis. Clinical picture is a small child with a swollen abdomen. I've seen that, and this is actually a very sad picture, right? You can see how this kid is sitting here with a very swollen abdomen. So although it looks like he's been eating just fine, he hasn't. He's very skinny everywhere else. The rest of this is just edema. It's not actually fat or anything, right? Kwashiorkor results from protein deficient meals. So malnutrition, edema, anemia, a fatty liver, and skin lesions. Basically, all this kid really needs is some protein. Right, so how sad is it that he can't access some protein? The last part is marasmus, which is this one over here. Malnutrition that doesn't cause edema. The diet is actually deficient in calories, right? But no nutrients are entirely absent. So he's also just hungry for the most part, but he needs calories, right? The other guy has calories. The kwashiorkor guy has calories, so he's functioning pretty all right, but he is still, protein deficient. So his body is breaking down everything else to make protein. That's what's happening to him. And because everything else is being broken down to make protein, all of that stuff that's broken down is decreasing the plasma oncotic pressure, low protein. Right? There is no protein in that guy. Let me see now. And then down here we have a question. So you see a 3-year-old boy with cystic fibrosis. So again, fat-soluble stuff, right? Cystic fibrosis is brought to the physician for a follow-up exam. His height and weight are both below the 10th percentile. On exam, he has a small, soft anterior fontanelle. There's marked outward bowing of the knees and medial displacement of the lower legs. An X-ray of the right wrist shows several radiolucent fissures with sclerotic borders in the radius and ulna. Which of the following lab findings is most likely in this patient? Right, so we're talking about fat-soluble deficiency because of cystic fibrosis, and then they're talking about, bowing of the knees and medial displacement of the legs. That's pretty much straightforward talking about vitamin D deficiency. And when you have vitamin D deficiency, you're going to have increased PTH, right? Cystic fibrosis is associated with exocrine pancreatic insufficiency and subsequent malabsorption of fat-soluble vitamins A, D, E, and K. Gene verum, which is what this kid is presenting with, and looser zones on X-ray, as well as late closing of the fontanelles and growth retardation are suggestive of rickets secondary to vitamin D deficiency. That's exactly what this 3-year-old boy is presenting with, rickets. Low serum vitamin D concentrations result in decreased intestinal absorption of calcium and hypocalcemia, which can cause rickets in children and osteomalacia in adults. Osteomalacia is pretty rare though, and osteomalacia is rarely ever going to be just because of vitamin D deficiency. It's also going to have other reasons why this adult has osteomalacia. This patient's serum parathyroid hormone concentration is most likely increased in response to hypocalcemia. Other typical serum findings seen in patients with rickets include decreased phosphate and increased alkaline phosphatase concentrations. Alright, so alkaline alk-phos would also be elevated. The next page starts talking about ethanol metabolism, which I've always said is actually a part of metabolism, not entirely just nutrition, right? And when metabolism gets started, that's going to be the next video. I'm going to try to do as much of metabolism and pretty much just finish all of it in one shot. We just finished all of nutrition and whatever genetics was left. So there's a lot of metabolism. Now, metabolism is the big deal, right? So that's going to be the one that you definitely don't want to miss. I'm probably going to do it tomorrow. And in metabolism, wait, what's tomorrow? Tomorrow's Saturday, right? Yeah, okay. I'm going to try to do it tomorrow, but I don't think so, because I know Saturday and Sunday we're having... Tomorrow, my family was invited to a dinner thing for Eid, and then Sunday we're having people over, so pretty sure both of those days are going to be pretty occupied. But if I don't do it early tomorrow morning, then definitely Sunday is when I'll be doing it. Sorry, Monday is when I'll be doing it. But you don't want to miss the metabolism lecture at all. Well, I mean, if you miss it live, that's okay. I'm still going to do... the videos are still uploaded for you to watch later as well. But make sure you grasp all of metabolism. You need to be able to talk about metabolism, all the little enzymes and stuff like that, without being confused about it. Right? You really need to understand what substrates you need, what little NAD, NADP, all of that, all those little things you need, and how they interact with each other, how your body kind of manages all of these guys with each other. And, the more you learn about it, the better, because as medical students, we don't really necessarily have a nutrition course, right? And many doctors are actually very bad at nutrition. But that's exactly the advice we need to give to all our patients who have diabetes. Just telling a patient take your medication isn't the best way to be a doctor. So make sure that you actually invest time into mastering all of the biochemistry and metabolism. Yeah, the physiology is also done. Are you going to follow the first 8 topic sequences, and in how many days will you finish this revision approximately? Honestly, I don't know how many days it'll probably take, right? Because it took us 2 days to go from all the way up to here. This is definitely going to take 1 more day to finish all of metabolism. Immunology is going to be another probably 2 days. Right, so I haven't really done because I honestly can't tell, right? I've never done it before, so I don't know how long it'll probably take to finish everything. But I do aim to finish everything this month because I'm not working or rotating this month, so I should be able to get everything done this month. And that's about it for now. So I'm gonna get going, get some lunch, and then I don't know if I'm gonna stream again today because I'm like really really sick. I'm just gonna take a nap and see. I'm gonna try to put together some other work for this PDF. But yeah, thanks a lot for joining today, and then I'll see you guys most likely on Monday. Just celebrating a lot of Eid stuff this weekend. Yeah, all right. Thank you guys. Bye.